chat, shout at me, and yeah, so we'll go. So first thing we're going to talk about is kind of the clinical practice of non-blanching rashes in children. So this was a study that I led. I had an awful lot of help and support from Ricky, from some of the speakers that are on today, Damian Roland, support for Waterfield Emergency Medicine, the health agency, and what we wanted to do was answer some of the group research questions. And I think we've done that. We've got the latest round of kind of what are the research questions, non-blanching rashes seems to have gone. No one's interested in it anymore, which I'm hoping we've answered some of the questions. So what I wanted to do was look at children presenting with fever and non-blanching rashes to emergency departments. So a little bit of background. So historically, meningococcal disease was reported as accounting for 10 to 20% of non-blanching rashes in children. And the reason for that was a lot of the evidence comes pre-meningococcal B vaccination, which came in 1999, and MSC, and then MenD vaccine, which came in 2015. Violence almost identical in terms of dates, a few months different, so we're very closely matched. And that has driven down rates of meningococcal disease. Also, it's quite hard to do research in emergency settings. It's relatively new concept to do it on a large scale. So we had to rely on retrospective data collection from inpatients. So although a lot of our guidance is built around old data, is also built around inpatient data. So actually, these weren't children with a non-blanching rash and temperature. They were children with non-blanching rash and temperature who got admitted by a paediatrician because they thought they might have meningococcal disease. So even the historical data was probably an overestimation. And then the other thing to say is that even kind of historically, even with quite cautious approaches, around 1 in 10 cases of miss. And when we say miss, that's not a judgment on the clinician, that reflects that meningococcal disease or enters by the nasal or pharynx. It gives you a runny nose and a bit of a cold to start with, so it's incredibly hard to spot. So, kind of imagine this winter, if we have no vaccinations, you're all going to see a case of meningococcal maybe once a week. How terrifying that would be in this current winter, with how many febrile children
on the YouTube stream.
Vaccines have been a huge success.
So what?
Is there many on the
side of this, so
yeah,
anyone who knows me and work with me, I'm quite keen on antimicrobial stewardship and trying to reduce the use of kind of just-in-case antibiotics. That said, we need to be very mindful of what this disease looks like. And this is a picture of a boy called Ezra, who I cared for. His family have been really supporting this kind of research, and they do permission to share these images as part of kind of education.
Yeah, I'm trying to think.
And for research. So, I don't want to miss the case. I want all of the Ezras to be treated really early, and I want them to recover and do really well, like he has done. But at the same time, I want to avoid treating absolutely every child with fever and TPI, so it's a really difficult task. As I said, it's just a graph showing really how vaccines have driven down the rates of meningococcal. So you can see it's based on all Irish data, just absolutely plummeted away over the years, and it's still falling. So I think interesting. I can see at the end where you put it in the chat, but I don't think we've seen any meningococcal since COVID, because of that's the measures that reduce spread of COVID, reduce the spread of meningococcal for Nigeria meningitis, and it was already coming from a very low starting point, and I think we've really driven that down. And remember, it's only reservoir is human, it's not an animal, no animal reservoir for Nigeria meningitis, it's an entirely human parent. So the study itself, so we wanted to look at children under 18 years of age with fever, or a history of fever and a new non-blanching rash. It was a prospective study over 2 winters between 2017 and 2019, where we wanted to compare different clinical practice guidelines with a really simple kind of objective. We did do a few other add-on things that were not main aim, and our outcomes were basically infection. The link there is to the trial registration of the protocol, the published protocol that we have in the register. We had 37 UK sites through Q, which is just phenomenal. We had 1,329 participants included, and screened 1,500, 90 cases. we only had 179 exclusions. Most of those were because they didn't meet inclusion criteria, which was to have fever and a really long rash. Only 21 were 2 years, the vast majority were vaccinated, then B and then C. Those percentages look slightly low, that's just to do with the age of vaccination, not to do with uptake. You give nearly half these kids IV antibiotics, and there's only 11 kids, so 1% will go into ICU. So on that side of things, it looks like it's why are we treating? But then if you look, 19 meningococcal, 9 of the ICU admissions were meningococcal disease, all of the deaths and the solid meningococcal. So it's that first slide again. Well, we're going to see lots of kids with non-blanching rash and temperatures. The vast majority of them need treatment, but it's a really big part. You don't want to miss those guys that do. The guys that need to be intensive care, the guys that are going to pass away if you don't treat them. So it's really tough. And I know when you have a patient in front of you,
just
you have the evidence base and you see the stuff really good.
Well, it's not lagging. It's just like it's not running at a very
we go back to the real beginning,
high quality.
10 to 20%.
Like it's not streaming it like you're hearing it now. If you go out of the room, you'll hear the quality difference. So.
10 to 20% of non-blanching rashes. Historically, we wanted to look at that. This comes back to this numerator and denominator. So in those studies, their numerator was meningococcal disease.
What's up?
And their denominator was actually fever and non-blanching rash. It was fever and non-blanching rash admitted to hospital via paediatrician. What we wanted was fever and non-blanching rash coming to the ED. Now, when I'm tired and not got the books in front of me, I'm going to make a decision of, and then it's rare. So you can say, well, actually, I've sent 70 home in my lifetime, and none of them ever had a problem. So I'm just going to send them all home, and then that's when you miss one. So I think it's the unintended consequence of having an overly sensitive guideline that you can't deliver. I think what kind of blew me away was actually the departments to develop a local guidance, which people can be resistant to, actually were the safest ones. Because you can say, well, this is pragmatic, it's safe, and this is what I'm going to follow, and actually that was the best balance. So I think that was the kind of real shock for me. I'm getting a message from Damian because I didn't talk about it. So when I talk about the febrile infants, I'm just to say I'm coming from the mindset of I want to send them home from ED. So I want to send kids over a month home that look well, have normal bloods, have had a period of observation with them, follow up at 24 to 36 hours, make sure that we haven't missed a urinary tract infection, and then if there's concern over urinary tract infection, treat that with oral antibiotics. And there's a really nice summary in Archives this month on that little article that was really good about antibiotics for urinary tract infections in infants. He's reminding me that obviously I'm talking to an audience, and I've worked in quite a few different places now where everyone under 3 months gets an LP. So we had some data in the study. Do you know what the average number of attempts for LP would be in the study? Well, I know you probably know this, Shane, but it's 3 attempts. So you think, I'll just do an LP. Actually, it's not. Because by the time you actually get a sample, on average, it's three attempts. That is not insignificant if you're thinking that you're looking for less than 1%. And if you then say it's 1% for everyone under 3 months, if you actually say, well, let's take away the kids under 1 month, we'll take away all those that have done well, if you're starting to get like 1 in 1,000, how many LPs are you going to have to do to find this patient? And you need to do it in the emergency room. Actually, if there's no signs of meningism, especially if we've got an alternate focus like a UTI, why can't we delay that procedure? And spare children these procedures. They're not pleasant things to have done.
Brilliant. Just another quick question. I remember you speaking before just on the specificity of purpura and fever versus the child with petechiae and fever. Even children say with the non-blanching rash, which may be suggestive of a HSP distribution, but the child has a fever in the department. How does that change your management, or would that?
On your head, beer, I think is the only thing I can say now for that. So, think about your wins. You're like, oh, well, I know there's 1,300 kids, but 10 of them had HSP, okay? If you want a group where you say, okay, I treated a HSP because it was a purpuric rash that was spreading and I had fever, I don't care when the next day someone comes, oh, why are we treating HSP with antibiotics? We'll stop them then. Invariably they go, well, I can't stop them now until the cultures come back. So, hindsight's 2020. I would treat that group. I would, because it's just such a small group, and it is where we do get it wrong. It's where you start. So, if you are 100%, pediatrician for 30 years, you don't care, you can stand over it, but on your head beer, I think, if I'm to be brutally honest. And if you're a junior, unless you can tell me you've seen 10 meningococcals and 10 HSPs, and you're certain that it's fine, you can stand in court and you defend that, treat them. Or if your bosses are saying you shouldn't be treating them, get them to come and make that decision.
Brilliant. There's no more questions in the chat. Just a quick question. I know you alluded just on the usefulness of doing a coag or coagulation studies in fever and petechiae. Probably isn't indicated in most cases, but can you just touch on that again, because there's a lot of variability amongst practice?
No, there are no cases where it's indicated. There's either well children coming in with petechiae and fever, coagulopathy. So what are you looking for? So if they're very, very unwell, you can look at DIC, or that, you're going down that route, that's a sepsis kind of route, that's fine. But if you're saying, I just wonder if those 7 particular spots in that temperature, is that sign that they've got that coagulopathy just never picked up all of their life, then that test just isn't indicated. That isn't the reason. But if you think it's indicated, actually, hematological malignancy is far more common. Appendicitis was more common. There were other differentials. So I think it's just, no, it's not indicated. It shouldn't be part of your routine workup. If you've got a good reason for it, it's different, but it shouldn't just be a tick list, everyone gets a card.
That's excellent. That's really good, Tom. No more questions coming in from the chat, so I think we might wrap it up there. That's brilliant, Tom. Thanks very much for joining. Really appreciate that.
Thanks for inviting me along. I rattled through a little bit. I'm so sorry about the technical issues at the beginning. Shane prepared me, met me yesterday. It's 110% my fault, and I'm incredibly sorry. So, but well done, Shane. It's been really, really good to get this organised. Well done.
Thanks, Tom. Great having you. Colin Black is the next presenter. He is a paediatric anaesthetist with a special interest in congenital heart lesions. He works as a consultant anaesthetist in Children's Health Ireland at Crumlin, and has completed a fellowship recently in Great Ormond Street Children's Hospital in London. So we're delighted to have him on today to talk about his special interest, which is very close to his heart. Okay, Colin, over to you.
Is my screen sharing okay there?
Yeah. Yeah, looks great.
Yeah, lovely. Okay, great. Thank you very much, Shane, for the invite. I've never actually talked to Shane about medicine. We've only discussed Arsenal and Arsenal football shirts. So hopefully he thinks I'm capable of giving a speech and talk about medical things as well. So as he said, I'm a consultant paediatric cardiac anaesthetist in CHI at Crumlin. I'm an alumnus of Great Ormond Street, where I completed fellowships in cardiac intensive care and ECMO and cardiac anaesthesia. So I work mostly with cardiac kids, be it in the cath lab or in bypass cases. So I'm going to talk about congenital heart disease and how it may present to the emergency department. It can be an intimidating subject because it's for various reasons actually. I mean, it's very acronym heavy, some of which are hard to understand or confusing. The kids can turn up blue, which is of course terrifying unless they're supposed to be blue. Single ventricles or kids with only one functioning ventricle can be intimidating. Babies with scars in the middle of their chest when you don't know what the diagnosis was or what they may have had done in the past can also be intimidating. And of course, the mainstay of most of our therapy in the emergency department and the rest of the hospital is oxygen, and sometimes that is contraindicated in some of these kids. Now, I am aware that I work mostly in the operating theatre, so by the time they actually reach me, at least I know what's going on, or more or less what's going on and what I'm dealing with. But of course, you guys working in the emergency department often don't have any information or very little to go by, so the circumstances are somewhat different. But in saying that, crucially, they have the same vital sign requirements as any other group of kids that you see, aside from the fact that occasionally the saturations are lower, but everything else should be targeted as you would expect for any other child. It's quite hard to be prescriptive in terms of treating congenital heart disease because there's caveats and they're all slightly different to each other, but I'm going to try and give you some practical tips, and it's going to be mostly clinically based, this talk. So I'm going to walk you through, again, a reminder of single ventricle anatomy, some of the physiological concepts around kids with single ventricles. I'll walk through the staged surgical palliation as a reminder that single ventricle children go through, and then some of the more common presentations to the emergency department and what your treatment goals might be, or some things to think about when you see these kids. So single ventricles can actually come in three different forms. So you could have a single left ventricle where the right ventricle is hypoplastic. You could have a single right ventricle where the left ventricle is hypoplastic. And very rarely you can get this single morphologically indistinguishable ventricle that functions as a single ventricle as well. Nevertheless, no matter what you're dealing with, they all need to survive mixing, intracardiac mixing, so most commonly via an ASD or sometimes a VSD, and of course a patent ductus arteriosus as well. Sometimes they have all three of these things, but without any mixing, these kids wouldn't survive. So I'm going to focus, for the purposes of this talk, mostly on hypoplastic left heart because it's one of the more intimidating ones, but the anatomy is relatively consistent as well, so it's nice for describing this population. So in hypoplastic left ventricle, as the name suggests, you've got a rudimentary, small, certainly not apex-forming left ventricle. You have a hypoplastic aortic valve and ascending aorta and transverse arch. You've got a mixing of the blood at an ASD level, most commonly, and a patent ductus as well. And crucially, the most important thing that makes them tricky in the long run is that their systemic ventricle is, of course, a right ventricle. So saturations in this population. So throughout this talk, you'll note that I refer to what saturations you'll be expecting in these diagnoses. And a hypoplastic left heart at birth, or any single ventricle at birth, really, SATs should be around 75 to 80%. So you get fully saturated blood returning from the lungs into the left atrium, mixing via the ASD in the right ventricle with the systemic venous blood returning, and you get SATs somewhere around 75 to 80%. After that, it becomes a little bit trickier, because now all the blood being ejected by the right ventricle into the pulmonary artery has a decision to make. The circulation is in parallel, so your pulmonary and systemic circulation are actually in competition with each other. So the blood can decide to go down the pulmonary arteries on the right and left to the lungs, or out through the PDA to supply the systemic circulation. So there's competition for blood flow at this point. I'm going to put up one of two equations. I don't know if you guys need to know these equations for emergency medical exams, but certainly these sort of things gave us nightmares studying for anesthesia exams. But this is Poisson's law. So the Q is blood flow through a tube, and that's influenced by pi times the pressure times radius to the power of 4 over 8 n, which stands for fluid viscosity, times the length. So these are the things that influence blood flow through any sort of tubular structure, obviously a blood vessel in this case. And you can see just by looking at it that it's quite obvious what the most important feature in terms of manipulating blood flow is, and it's the radius, because you can see the radius is to the power of 4. So if we work that into an example, if we take, for example, this tubular structure here, and before any manipulation, the blood flow through this structure is 100 cubic centimeters per second. If we manipulate some of the features of the tubular structure, everything else remains equal. You'll see that if we double the length of the tube, this halves the flow rate to 50 cubic centimeters per second. If we double the viscosity, that also halves the flow rate because it's on the bottom side of the equation. But on the top side, we could increase the flow rate by doubling the pressure. But if we double the radius, we actually increase the flow rate through this tubular structure by 16-fold. So you can see the influence that the radius or diameter of a blood vessel has in terms of where the blood decides to go. You only need a small 19% increase in the radius of a vessel to actually double the volume flow rate. So it's very, very significant. So this is the key concept for understanding these things. And this was the concept that took me a long time before I actually figured out congenital heart disease, is that blood flows down the path of least resistance. If you remember that, you will remember most of the physiological concepts. So when it has a choice, it goes down the path of least resistance, and radius of the vessel is the most influential feature in terms of influencing that blood flow itself. So the second equation that also gives us nightmares is what's called the shunt equation. And this is where the concept of a balanced circulation comes into play. So when you've been studying or reading about single ventricles before, you'll often hear, is the circulation balanced or is it unbalanced? Well, the shunt equation is really what we're talking about here. So the shunt equation tells you the QP to QS ratio. So QP being pulmonary blood flow and QS being systemic blood flow. And the features or the numbers that you plug into this equation are shown in the bottom left there. So SaO2 being your whatever arterial sat that you get on either arterial blood gas or on your sat probe, minus the systemic venous blood, so that's the blood in your right atrium, for example. And on the underside of that equation is your SpVO2, so that's your sats in the pulmonary veins, so that should be 100% if your lungs are functioning normally. And your SpAO2, which is the blood flow in your pulmonary artery, which is more or less the same as your systemic venous return. Occasionally it's slightly lower because the coronary sinus drains directly into the heart, but for the purposes of this, they're just going to be the same. So if we plug the numbers into that for any healthy person, who's got arterial saturations of 100 and say mixed venous saturations of about 75. So the difference between arterial and mixed venous saturations is somewhere around 25 or so. So if we plug those numbers in, you'll see that the QP to QS ratio is 1 to 1. So that's in a healthy person without any shunting. You've got equal volumes of blood going through the pulmonary circulation as you do in systemic circulation. If we put the numbers in that I showed for the hypoplastic left heart child, you'll see that I'm going to use 80 for this example. So they had arterial saturations of 80. If we use the same similar ratio of arterial to mixed venous saturation difference of about 20 to 25, I'm going to call it 60, a mixed venous of 60 here. And then their pulmonary venous blood should be fully saturated at 100. But their pulmonary arterial blood is the same as their systemic arterial blood because the blood is only exiting one route via the heart and then it has a choice. The saturations are the same. But you'll see if we plug those numbers in, again, we will have a QP of QS of 1. So if you get a single ventricle child before they've had any surgery or even one after surgery of saturations around 75–80%, the QP/QS is probably around 1, so that's a balanced circulation. But in the preoperative period, before they have any correction, of course we know that the pulmonary vascular resistance drops quite precipitously in the first few days and weeks of life, and this is when the kids can run into trouble, particularly an undiagnosed hypopath who presents to the emergency department, for example. So we'll use a few more examples here. If we adjust the saturations, okay, so if you have a single ventricle, a hypoplastic left heart who comes in with saturations of 85%. So if we substitute those numbers in, you'll see that if the sats are 85%, the QP/QS is now 1.3 to 1. So we have more blood going down the pulmonary circulation than we do the systemic circulation. If they come in with saturations of 90 or even 95, you can see that that adjusts the QP/QS ratio to 2 to 1 or even 4 to 1. And this obviously isn't good because you are now compromising your systemic blood flow and your systemic oxygen requirements because there's so much pulmonary circulation occurring where you don't want it to happen. So this is what we describe as an unbalanced circulation. And if the circulation remains unbalanced for a long period of time, well, actually it doesn't even need to be that long. You can certainly run into physiological trouble and a child can become pretty sick pretty quickly. So what can we do about these situations? So if in the bottom left here, I've got a pie chart. So normally we've got a QP/QS of 1 to 1. So half your blood flow is going to the lungs, half is going to the rest of your body. In this example above, if the QP/QS is 4 to 1, now 80% of your cardiac output is going to the lungs and only 20% is going to your systemic circulation. Now obviously this is going to be insufficient to meet the metabolic demands of the rest of your body. So how do you manipulate that? Well, we will talk about manipulating QP in a little bit, but we can also manipulate the DO2. So this is, well, there are only 2 equations, there's a third. The DO2 equation is the delivery of oxygen to the body. So that is a factor of your cardiac output multiplied by this thing called Hufner's constant by the hemoglobin by your saturations. So if we increase the DO2s, that's basically increasing the size of the pie. You can, to some extent, improve your or meet the metabolic demands of the heart. So you can sort of figure that the area of this slice of the larger pie is possibly equivalent to the slice of the smaller pie down here. So we can increase the cardiac output or hemoglobin to some extent to temporize these issues. But the cardiac output has to increase to meet this metabolic demand. So it doesn't come without consequences itself. So the babies will become tachycardic and they will increase their SVR to some of the non-essential vascular beds, putting them at risk. This increased heart rate and increased work that's required of the ventricle shortens the diastolic filling time. You get more pulmonary steal, so your QP/QS can be worse. You get a volume-loaded, overloaded ventricle because you have all this pulmonary blood flow is going round and round in circles. When you get a volume-loaded ventricle, it becomes pressure-loaded over time as well. So you get a raised EDP, which is your end diastolic pressure. If your EDP is high, it means that perfusing the endocardial muscle becomes tricky as well, and then that becomes ischemic, and of course then we get into territory of ventricular failure. There are consequences of the pulmonary overcirculation itself, in that over time you get pulmonary arterial hypertension. That's due to actual irreversible microvascular changes to the intima of the vessels themselves, resulting in elevated pulmonary vascular resistance. And then again, the volume overload and failing ventricle can cause pulmonary venous hypertension just by high pressures in the ventricle and the common atrium, meaning that pulmonary venous drainage becomes difficult as well. So that's why we have to have, this is why they need surgery, basically. We need a way to restrict or control their pulmonary blood flow, and in addition to that, reduce their ventricular workload as well. So, the surgical palliation for single ventricles. So I'll talk through the 3 stages of palliation. What I would say is, if you do encounter these kids, is ask the parents about the kid and what operations they've had, because the parents are very well counseled, they're very well versed in the actual operations. They'll know what saturations their kids have or have had at outpatient appointments. Sometimes they even have sat probes at home as well. So they'll be able to tell you if they've had a Norwood, a Glen, or a Fontan. So you just need to remember what saturations are expected in that sort of in that anatomy, in that configuration. So parents are a wealth of knowledge. So stage 1, surgical palliation, is what's called the Norwood procedure. So we started with the hypoplastic left heart on the left, and this is what they end up with on the right hand side. So the Norwood procedure is performed usually in the first week of life. There's 4 parts to it. In terms of neonatal sternotomy, so if you have a small kid with a sternotomy wound, there's not that many neonatal operations we perform. So a Norwood is relatively rare. More commonly would be a TGA, so transposition of great vessels, so they've had an arterial switch operation. In terms of neonatal surgery, a coarctation repair is more common, but that's obviously via thoracotomy. So small kids with, small infants with sternotomy scars, they haven't had that many operations, but there's not that many they could have possibly had at this point. So there's 4 parts to a Norwood procedure. So the first thing they do is an atrial septectomy. So they hack away whatever is left of the intraatrial septum to make sure the mixing is perfect. The second thing they do is they take this lovely big normal-sized pulmonary artery and they sort of Frankenstein it onto the ascending aorta here using a patch to create this lovely neo-aorta. They get rid of the patent ductus arteriosus here. So now you can see we've got lovely blood flow out into the systemic circulation, but we have no source of pulmonary blood flow. So what they do is they put in a little graft here, that's called a BT shunt, which goes from the right subclavian artery to the right pulmonary artery. And it's very small caliber. We're talking 3 or 3.5 millimeters in diameter here. But from what I previously told you, you can see even a 0.5 millimeter diameter increases the radius enough to really increase the pulmonary blood flow. So on occasion, or very rarely, we can oversize or undersize these shunts. This will also result in a murmur. So a murmur you can hear over the right second intercostal space as well. So that's a shunt murmur, something to just bear in mind. So after this operation, it doesn't do much in terms of the saturation. So the mixing is the same, the sats exiting the heart is the same, and now the blood flow is still in parallel. So the blood can go down to the lungs via the shunt or systemically via the new neo-aorta as well. So we actually haven't changed a whole lot physiologically. The sats are no different to they were before we started. But what we do have now is really secure, systemic and restricted pulmonary blood flow. So that reduces the risk of pulmonary arterial hypertension, it reduces the volume load and thus the work on the single ventricle as well. We've got really secure mixing at the atrial level, and crucially they can get off Prostin and start oral supplemented feeds, and of course go home at this point. So the next operation on the pathway is the Glen, or bidirectional Glen. This happens at around 3 or 4 months of age. It's an extracardiac operation, meaning the internal anatomy now doesn't change. And what they do is they take down the BT shunt and they produce a new source of pulmonary blood flow by connecting the SVC directly into the right pulmonary artery to supply both lungs. They choose the SVC as opposed to the IVC because, of course, infants this age have absolutely ginormous heads, so most of their cardiac output goes to the head and neck and arms, where it is drained by the SVC. So you get more of your cardiac output returning to the lungs via the SVC. So that's why they plug the SVC in first. Saturations go up a little bit. So your pulmonary venous blood is still fully saturated, but the mixed venous blood is now less desaturated than before, and then the mixing of them together gives you sats usually around 80 to 85 or 86, 87%, which is a really good saturation for a glen. The reason the sats go up is because there's a concept called effective pulmonary blood flow. So if you have a higher proportion of fully desaturated blood now returning to the SVC without mixing in the heart, you get much more bang for your buck, and a higher volume of blood is now fully saturated returning to the heart. So the dilutional effect of the IVC blood is less, and thus your saturations improve. So sats go up with the glen. It further reduces the volume and workload on your systemic ventricle. You get even more secure pulmonary blood flow, and it increases your saturation for the reason I described there. But crucially, it relies on passive blood flow. So there's no pump now in this circulation. Circulation is now in series, but it's not supplied by a pump. So the blood has to flow passively across the pulmonary capillary bed. So you can imagine it doesn't work efficiently or won't work at all if there's elevated pulmonary vascular resistance, or if there's any obstruction to flow with like a thrombus or particularly small pulmonary vessels, or if there's very bad pulmonary venous hypertension due to ventricular failure. So, I mean, we take central lines out quite early in this population just so that there's no sort of nidus for a thrombus to grow and block off this circulation. And the third and final stage of this palliation for all single ventricles really is a Fontan operation. So it actually isn't a Fontan anymore. That was the original operation, but everyone still calls it a Fontan. It's now more accurately called an extracardiac fenestrated Fontan, or to be perfectly correct, it's a fenestrated TCPC, which is a total cable pulmonary connection. And this is another extracardiac operation where they now disconnect the IVC from the right atrium, and they put a synthetic graft from the IVC, and redirect that venous return directly into the right pulmonary artery as well. And they leave a small fenestration, so that's a small communication here between the graft and the common atrium. Reason being, when you come off bypass in these cases, and this is all plugged in, the lungs just aren't quite ready to accept the entire venous return passively, so the pressure can be quite high here. So the circulation does not particularly run effectively in the immediate post-operative period. So in order to maintain a cardiac output, there's a little fenestration here so blood can pop into the ventricle and maintain your cardiac output. Your sats will be a little bit low initially, post-operatively, but over the course of 2 or 3 days, they should look something like this. So we improve our effective pulmonary blood flow again. So we're completely in series now. All your venous return is going to the lungs. Thus the majority of your cardiac output should be fully saturated, coming back to the heart. We usually don't get above 95%, but a very good Fontan will get saturations of 95% or so. Again, it further reduces volume load and work on the single ventricle. We get better exercise tolerance, the kids have more energy, and saturations go up. But again, we're still entirely passively dependent on pulmonary blood flow. So for the same reasons as before, it will not work if we've got high pulmonary vascular resistance, if there's clot, if the ventricle is actually failing itself. So we do a full workup before we decide to go to Fontan in the cath lab to make sure that the system will actually function properly when it's all plugged in at the end. Over time, the Fontan can fail, and it will. So hypopasts live into their 20s at best, really. And some of the chronic complications you see from elevated or sustained elevation of pulmonary vascular resistance are things like liver failure, plastic bronchitis, chylothoraces, and protein losing enteropathy as well. So that's a sort of quick run through the stage palliation of that goes for pretty much all single ventricles or anything with a functioning single ventricle. Some biventricular circulations end up like that as well, but that's a little bit more, there's a few more nuances to that. So in terms of acute presentation, so you might just be faced with a baby like this, looking a little bit worried with a scar in the middle of his chest. So the most important things to think, or I think you should ask yourself if you encounter them, is what are the expected saturations for this circulation? And does the circulation appear to be balanced? So if you hear the word Norwood, you know that the sat should be 75 to 80. If you hear the word Glen, it should be 80 to 85. And if you hear the word Fontan, it should be over 85 and preferably over 90. Also think of what things that you can do when you're assessing or treating them that will affect the performance of the circulation. And what I really mean by that is what drugs or therapies that you could give or will give how will they affect QP and QS, or how will they affect the pulmonary and systemic vascular resistance. But in saying that, don't forget the basics, and I'm sure you don't, but just because they've got a cardiac problem doesn't mean that the reason they're sick is because of their hearts. They still need all the other things that you would do for a sick child presented to the emergency department. Crucially now, I am aware that most of these kids, I mean, there's only one cardiac centre in Ireland, so the majority of these kids, when they're sick, do not present to our hospital. So I'm saying if there's an echo available, it's amazing, but I do recognise that this service may not be available, and someone skilled in actually doing paediatric echo is an even smaller resource, but it gives you a wealth of knowledge if you can do it. So before we talk about some of the scenarios, how do we manipulate QP and QS? So if we decrease someone's pulmonary vascular resistance, we will encourage pulmonary blood flow. So some of the things that we do or can do, so oxygen is the most potent pulmonary vasodilator we have, followed closely by inhaled nitric oxide, which you probably don't have access to in emergency departments, but certainly in intensive care. Milrinone also decreases your PVR and improves your pulmonary blood flow. You may see some kids coming in on sildenafil or bosentan, so they are surefire signs that they've had trouble with high PVR in the past and are on treatment for that. Your pH is or your pulmonary vascular resistance is very sensitive to pH, so it's lower with lower pHs and higher. The opposite. It's high pH will cause lower PVR. Lung volumes as well. So if you remember from physiology days, your at high and low lung volumes, your PVR is at its highest. So tidal breathing with a normal functional residual capacity, you will have the lowest pulmonary vascular resistance. So if you have low lung volumes due to, say, pneumonia or something like that, that will increase your pulmonary vascular resistance and decrease your pulmonary blood flow. Spontaneous breathing, so negative intrathoracic pressure. When you breathe by yourself, it actually pulls blood into these passive circulations. So that reduces pulmonary vascular resistance. On the opposite side, if we increase pulmonary vascular resistance, which you may need to think about, it'll impair pulmonary blood flow. So things that do that are low FiO2s. So there was a time when Norwoods or pre-operative single ventricles would have been nursed in boxes that gave FiO2s of only 18% to improve or to increase the PVR and thus reduce the risk of pulmonary overcirculation. Catecholamines do increase your PVR, but they have such a beneficial effect in terms of increasing cardiac output that they don't really impair pulmonary blood flow, they actually help it. And as I said, up above, lung volumes as well. So collapsed lung or overventilation will increase your pulmonary vascular resistance. The opposite end of pH, so acidosis, and positive pressure ventilation itself will impair pulmonary blood flow. So of course, ventilating or the decision to ventilate shouldn't be taken lightly, and certainly not if someone is very, very unwell in a Fontan, as I'll allude to in a second. So on the opposite side, decreasing your SVR encourages systemic flow. So things, basically all the drugs that you may use to induce anesthesia, aside from ketamine, will reduce your SVR. And afterload reduction, pharmacologically, milrinone will encourage systemic flow. Or some of these kids are on long-term captopril as the ACE inhibitor of choice to reduce SVR and encourage systemic flow. And increasing SVR obviously impairs systemic flow. So if the cold child or someone on vasoconstrictors or with too much fluid on board. So we get into some clinical scenarios, but don't forget that blood flows down the path of least resistance. So don't forget that caveat, okay? So a stage 1 Norwood. So a hypoplast has had a Norwood on day 3 of life. They were discharged at day 13 on aspirin, and they present back to the ED a week after that. And now they're not feeding, big distended abdomen, they're cool, peripherally mottled, tachycardic, tachypnic, but afebrile. They have a lactate of 5.7, and their saturations are high, they're 94%. So the question you need to ask is the circulation balanced? Well, it's quite obvious in this case, I think, that the circulation is not balanced. The saturations of 94% will give us a QP/QS of something like 4 to 1. So it's most likely in a scenario like this that they are over-circulating. You see this in a preoperative child, but it can also happen in a post-operative Norwood if, for example, the shunt is just a little bit too big. This sort of presentation is less commonly will be less common after they've had a surgical correction, because if the shunt is too big, we usually recognize it in the intensive care. It's more likely that you'll see this over-circulation scenario in a child that hasn't been antenatally diagnosed with hypoplastic left heart or a single ventricle. So they're shocked systemically because they're over-circulating, and the systemic circulation is not getting enough oxygen to meet the metabolic demands, basically. So what we want to do in this scenario is think of how can we reduce pulmonary blood flow. How can we improve oxygen delivery by manipulating cardiac output and the hemoglobin? And how can we decrease oxygen consumption itself? So sometimes ventilation is the only way to do that. In this scenario, oxygen will exacerbate this situation. So despite the fact that they're shocked, they're obviously having anaerobic metabolism in the systemic circulation, oxygen will actually make this situation worse. Another scenario you may be faced with in a post-operative Norwood is, so the same scenario, they had Norwood, discharged home, they're on aspirin, they come back in a week later though, they're febrile, they're tachypnic, they have a Broviac or another long-term line in situ, and they've a lactate that's not too impressive, and they're desaturated. So is the circulation balanced in this example? Well, to be honest with you, it's a lot more difficult to figure out in this scenario, and I wouldn't be able to decide myself without more information. So the desaturated Norwood is a tricky one. So this is what we have, our lovely post-op healthy Norwood that everything's gone well, and now you're faced with someone who's got arterial saturations of 63%. So what is the reason that they're desaturated? Well, they can be desaturated for basically 3 different reasons. The first being they can have pulmonary venous desaturation. So the venous blood returning from the lungs is not being fully saturated. So basically they have lung failure. They've the gas exchange for whatever reason isn't up to scratch. So are they aspirated? Do they have pneumonia? So that will cause a pulmonary venous desaturation. Will thus cause a systemic venous or systemic desaturation in the Norwood. The second place they can be desaturated is they can have pulmonary venous desaturation. Why? Because are their oxygen requirements higher than they are before? So are they using more oxygen? Are they septic? Are they anemic? So the oxygen extraction is higher than, or is too high? Do they have a low cardiac output state? So the actual cardiac output delivering oxygen to these tissues isn't sufficient. So they can have pulmonary venous, they can have systemic venous desaturation as well. And thirdly, and probably most scary, they can have a very, very small or very low pulmonary QP/QS ratio. So they have little or no pulmonary blood flow at all. So is the shunt blocked in this situation as well? So it's a little bit more tricky figuring out what's going on with the desaturated Norwood. And it's very important because the vast majority of interstage deaths in these kids occurs between the Norwood operation and the Glenn operation. So that's kind of the highest risk area. So the desaturated Norwood, if you suspect pulmonary venous desaturation, so lung failure, I guess, treat the cause. If they have aspiration, if they have pneumonia, start treatment as you would for that. You can use oxygen in this situation, but use it judiciously. So if we're dealing with SATs of 63%, only give enough oxygen to get them to the 75% target and no more than that, okay? Because excessive oxygenation or excessive oxygen can can confuse things and can manipulate your QPQS even in a post-operative kid. If you suspect systemic venous desaturation, treat their sepsis, treat their low cardiac output state, treat their anemia, judicious oxygen as well, just to hit the target that you want. And can you reduce their O2 consumption? Occasionally ventilation is the only way to do that as well. Or do they have extremely low QPQS because the shunt is blocked? So can you hear the shunt murmur? So if you ever come across these kids, I encourage you to listen for the murmur because it's quite obvious. And if you can't hear it, if it's very quiet, then alarm bells should be ringing that the shunt could be blocked. In these situations, it's difficult. You need to chat early to your cardiac centre. They probably advise you to give some heparin, give as much oxygen as you need because you need to fully oxygenate whatever blood is getting to the lungs in that situation. But do that on discussion with the cardiac centre. So a Glenn coming in, unwell. So there's a 10-month-old, another hypoplast. We've had a Glenn 6 months ago. They're on aspirin. They come in vomiting, diarrhea, not taking anything orally. They're cool and peripherally shut down. So their saturations are 70%, which we know is low because we know a Glenn should have sats of about 80 to 85%. Their chest is clear, however. So in any passive circulation, volume is really the best place to start. So in the Glenn or Fontan, you will never really go wrong by giving them a big loading dose of volume because these passive circulations don't work when when you're dehydrated. The reason being, there's a concept called the transpulmonary gradient. So if you measure your Glenn pressure, so say via a jugular vein, so what would have been your CVP is now your Glenn pressure because it's communicating directly with the lungs themselves. You need to have some sort of pressure gradient from your Glenn circulation to your common atrium. So there needs to be a pressure gradient to drive blood across the lung fields themselves. If you're completely empty, that gradient becomes smaller and smaller, and the system doesn't work particularly effectively. So these kids need volume and lots of it sometimes. You can give Glens as much oxygen as you want because our circulation is now in series, so you're not going to steal blood from another vascular bed by giving oxygen. So you can use as much as you need to achieve the saturations that you're aiming for in this situation. So desaturated Glens, again, they can have gas exchange problems. So do they have a lung problem? Treat that. Do they have a more prolonged or chronic elevated pulmonary vascular resistance due to pulmonary arterial hypertension? But even the lung problems themselves, the pneumonia or the atelectasis can cause increased PVR and make this circulation a little bit less efficient. Sometimes they have hypoplastic vessels and sometimes they have a thrombus, and some of these things you may not be able to do anything about in an emergency department situation. They could also be desaturated because of ventricular failure or severe valvular regurgitation, resulting in high pulmonary venous hypertension as well. There's a thing called veno-venous collaterals, which are these little veins that start to cannulate from the SVC circulation down into the IVC circulation that can cause desaturation events as well, but they are a little bit rarer and can only be diagnosed really with echo bubble studies, so not something to be too bogged down about. So these kids, volume, as much oxygen as you need. Milrinone is really helpful, and often a loading dose is quite good. 50 mics per kilo loading dose will reduce your pulmonary vascular resistance quite nicely and make this whole system a little bit more efficient. And ventilation might be required in these kids as well. The Fontan, so around 4 years old, they've had a Fontan 9 months ago. They come in febrile, coughing, poor intake as well. They're desaturated at 80%, and we know that's low because now you know that Fontan should have sats at least over 90%. But they have a big consolidation on their chest x-ray. So one question to pose when a Fontan is coming in, and a crucial question to elicit is the Fontan circulation failing? So have they been getting sicker and sicker over time, or is this a more acute presentation? The one that's been failing over time is a more dangerous presentation, and they can be a lot sicker, and making a decision to ventilate those kids can be very, very troublesome, and even the process of anaesthetizing them can be quite difficult. However, if they just have a pneumonia, and if you treated that, they could improve, then that's a slightly different scenario. But don't forget, the blood flows down the path of least resistance. So these Fontan children, most centres, certainly in our centre, we leave fenestrations. I know Great Ormond Street often didn't leave a fenestration, but You can be desaturated acutely because of a high pulmonary vascular resistance due to pneumonia, for example, and there's just blood shunting as well as the lungs not particularly working very well. So there could be several things at play in this situation. A sustained elevation in your pulmonary vascular resistance or your pulmonary venous system, your pulmonary venous drainage will cause fontan failure. And in that situation, they're desaturated because they are just chronically shunting across their fenestration because the blood simply cannot go up into the right and left pulmonary artery. And those are the kids that are sort of steadily declining, that are the ones that should ring alarm bells a little bit more readily than the one that's become acutely unwell. So I wanted to just give one little quick 2 slides maybe on biventricular circulation. So let's say these are kids with large left to right shunts. So usually unrepaired ASDs, but ASDs less so unrepaired VSDs, AVSDs, or even a large PDA who's presenting with symptoms of cardiac failure. So, poor intake, tachypnic, recurrent chest infections, etc. They run into trouble when these defects, so we use VSD as an example, if the defect here is unrestrictive, the QPQS could be absolutely massive. So if you imagine when the LV is in systole, a lot of what the LV is trying to eject into the aorta is actually just crossing the VSD and going into the lungs themselves. So it's continually increasing the saturations that are in your pulmonary artery and going to the lungs. So if we plug some of those numbers in, so in a situation with a large left to right shunt, the number that's being manipulated in the shunt equation is your PA sat. So the more blood that's actually shunting from the left to the right means the saturations in your pulmonary artery are increasing. So as the sats in your PA, due to the size of the defect, is going up from 80 to 85 to 90 to 95%, you can see that the QPQS ratio can be up as high as 5 to 1. So if a kid comes in unwell with an unrepaired VSD, for example, or AVSD, and they're very tachypnic, they're not feeding well, you're not sure what's going on, it's quite, you wouldn't be the only person to think, well, we'll just give them a little bit of oxygen. But again, if you give these kids loads and loads of oxygen, it's just going to make it easier and easier for the left to right shunt to increase the volume of blood that's being shunted across to the right-hand side. And you can exacerbate problems like this in these situations. So I think in someone who's got an unrepaired left to right shunt, accept saturations in the lower 90s because sometimes oxygen will actually exacerbate these situations. So I'm going to wrap up here, hopefully not too bad on time. In respiratory illnesses then, oxygen can exacerbate situations where there's large left to right shunts or in an unrepaired or stage 1 Norwood. Consolidation increases the VQ mismatch and causes pulmonary venous desaturation. And high PVR from lung problems can also affect the passive flow in glens or fontans. Dehydration is not tolerated in single ventricles and actually can cause shunt thrombosis due to the low flows. Sepsis obviously increases oxygen consumption and puts excessive strain on a single ventricle by the attempts to increase cardiac output. And don't forget it as a cause of desaturation in Norwoods and glens in particular. In cardiac failure, low cardiac output states, think in single ventricles, milrinone's great, adrenaline, give them volume and adjust or increase, be pretty generous with their hemoglobin. And in high cardiac output states, so high or big left to right shunts, increasing the PVR will make things a little bit worse, so be judicious with your oxygen and try and reduce the afterload and diurese. That would probably be the most prudent things to do. So in summary, talk to the parents. The parents are a wealth of information. They'll tell you what operation they've had and what the SATs should be, what they've been measuring over the last number of weeks. Don't forget the simple things because they can, still treat sepsis as you would treat sepsis. Generally speaking, just target normality. So the saturations that you expect, aim for blood pressure that you should expect, aim for heart rates that you would normally expect as well. Milrinone is very good, and you can't really get into our hospital as a cardiac child without being given Milrinone. We're very, 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 very liberal with Milrinone use. don't fear ventilation. It could be life-saving in these kids, but just have a good think about it before you do, and probably discuss with your local centre as well. An echo if possible, but it's not always possible. And certainly our cardiac centre is very available on the phone for discussions, so don't be afraid to call them. There's never a bad question in terms of congenital heart disease. So I think I'll open for questions.
That's excellent, Colin. That was a brilliant talk. Thanks very much for that. I just have a quick question just on some of the more practical aspects of managing, say, a baby in a regional centre with undifferentiated duct-dependent lesion. Say it's a couple of weeks old, you suspect there might be a hypoplast or coarct. You spoke a bit about oxygenation and ventilation. Just in terms of when you have a definitive airway versus when you don't, and secondly maybe just a little bit on Proston, any practical considerations on starting Proston peripherally in a peripheral centre?
So I mean, Proston is, I'll be perfectly honest, I've never started someone on Proston because I've always worked in a centre where someone comes with Proston. To be honest with you, if there's any doubt at all about a cardiac disease in an unwell neonate, Proston should be one of the first things that you go for. And I would usually start it at a higher dose than possibly recommended, because if it is a question of your PDA closing and that's what's causing the deterioration, I think it's certainly prudent to start it as early as possible and to get that PDA back open again. I mean, I do recognise the difficulty of being in a regional centre where you don't know the diagnosis and it could be one of several things. So generally speaking, you're treating all these things at the same time. You'll be treating these kids for sepsis as well as considering congenital heart disease as well. There's no real neonatal things that I can think of that Proston would cause deterioration or would not be recommended. So I think just start it. A clinical exam or an echo is certainly it's a worthwhile exercise, because of course murmurs or any sort of murmur, just consider congenital heart disease and start them on Proston, I think. Yeah.
Excellent. Just a quick question on fluid boluses. So, say, again, similar child with a duct-dependent lesion, a baby, obviously their lungs might be a bit wet, they might be fluid overloaded, but peripherally they might appear shocked. If you don't have an echo and you're not really sure if their circulatory system is balanced, how would you advise just on administering fluid boluses, say, before transfer?
Yeah, no, that's a good question. You know, I think you wouldn't be wrong to give a 10 per kilo fluid bolus, but if you're considering congenital heart disease as a cause of the problem, I would give further boluses very judiciously, I guess, because you will probably exacerbate your QP, QS a little bit. It's a case of giving a bolus and then measuring whatever you're targeting in terms of improvement. So repeat your cap gas or whatever you're using in terms of measuring lactates, I guess. That's particularly in the small ones. So I would give a 10 per kilo bolus, but I would be judicious thereafter if there is a consideration for congenital heart disease. I think personally, I'm not a huge fan. I'm an anaesthetist, so I just stick in central lines and start inotrope instead. Inotrope's a lot better than giving fluid. I think we're all realising that in terms of even managing sepsis. So I would start with a smaller bolus, I guess, and then think about it thereafter. If you have a Glen or Fontan, though, I would be straight in with a 20 per kilo bolus, because volume is absolutely crucial to those guys. So don't be afraid of giving extra volume in that situation, I think.
And just from a practical point of view, with your anaesthetist hat on, are these children particularly difficult to intubate and then subsequently ventilate compared to, say, a sick bronch or just a septic child?
No, I mean, you're straightforward. Your standard congenital heart disease kid isn't, in terms of actual airway management, no, they're not more difficult to intubate unless they have congenital heart disease associated with another syndrome. So, I mean, obviously Down syndrome kids present with AVSDs. They, I suppose, technically can have a slightly more challenging airway, but usually they're manageable, and there's a few other rarer things that could be associated with congenital heart disease, like Beckwith-Wiedemann, for example, that can have more challenging airways. But generally speaking, if they morphologically or phenotypically look like a normal child, then generally speaking, their airway isn't any more tricky than you can expect with any other kid. So I wouldn't be scared of airway management if you think that's the way that you need to go.
And just with more children and families opting for the palliative route and going to the Fontan stage, do you see a lot more children presenting older and sicker post-Fontan? They've had their 3 stages and they get quite sick when they're older.
Yeah, well, Fontans are funny because you can see failure at different stages. So some of them fail quite early and are palliated even earlier. We're very, very good at determining when or who should have a Fontan and who shouldn't, because if it fails early, we didn't work them up correctly at Glen stage. So most of them are pretty good once they've got it. Now they do start to fail sort of late teens, early 20s. So, they have graduated from paediatric services a lot of the time there. So the sort of grown-up congenital heart disease is now more, it's an evolving specialty in itself. So a lot more of those people are presenting to adult services. We're actually seeing a lot less single ventricle kids in Crumlin anyway. There seems to have been slight shift in terms of, since our termination of pregnancy laws have changed, we are seeing less hypoplasts and less single ventricles, so it's actually becoming a little bit rarer for us. So we may see less of them in future, but there's always going to be a few floating around, yeah. But they generally do well because we've selected them well, I think, in the initial phase.
Just a question in the chat. When working up a pre-Fontan, if it's decided they aren't suitable for a Fontan procedure, are there any other treatment options? I presume we mean surgical here.
No, there's not, unfortunately. So they all come to the cath lab and we do a pulmonary vascular resistance study, we do echoes, and it's all done to sort of calculate what the Fontan pressure might be when you do a Fontan, and if the pressure is estimated to be too high, we know that they're going to fail pretty much straight away. So the option is to not proceed for surgery at that stage, and unfortunately they're switched to comfort measures. In saying that, it doesn't mean they're going to die imminently. I remember anaesthetising a kid for a heart transplant in Great Ormond Street who was 10 years old with a Glen. So they will, the Glen is not a long-term solution, but they will just get more and more profoundly desaturated as they get older because they just outgrow their Glen. Over time, of course, your IVC venous return becomes the greater proportion of your venous return than your SVC. So when that sort of switch happens, they just become profoundly desaturated. But there's no other surgical option, unfortunately, at that point.
Excellent. And just a quick question from the YouTube chat. How common are apneas with high-dose prostaglandin? Is that something you encounter practically?
Yeah, we do. I don't work in intensive care, but yes, it is pretty common. And I guess the higher dose puts you more at risk of apneas. So we do, on occasion, have to admit people to ICU for apneic events. And I know the question is probably, I don't really want to start high-dose prostin in the community, but and that's fair enough. And it is a judgment call, I guess, if you're starting it peripherally. But yeah, no, the higher the dose, the more likely you are to have apneic events. But we're not, I suppose, in a hospital scenario, we're not scared to use higher doses because we're there to manage them. But I understand the difficulty of doing that somewhere where you may not have airway management skills.
That's brilliant, Colin. Thanks very much. I can't let you go without mentioning your book. So, Colin, if for anyone who's found that talk interesting or enlightening, Colin's written a book recently entitled Gas Man, which is an autobiography and a series of short stories and memoirs from his experience working in Crumlin and London. And it's a very funny and interesting read, plenty of medical anecdotes and also funny anecdotes as well. And that's available in all good bookshops, Colin, isn't it?
It is, Shane, yeah. Shane's not even on commission, so thank you for the plug there. Good man.
We're coming up to Christmas, so it'll be a nice stocking filler. Listen, thanks very much for that, Colin. Really interesting talk, very helpful, very useful for emergency clinicians.
You're very welcome.
We'll let you go. We might have a 5-10 minute break, come back at 11:45 with Nisha, Balan talking about mental health presentations to the ED. So 10-minute coffee break. Thank you. What did you say?
The break type thing. Yeah, share the screen. Go to the just swipe through to the breaktime. Yeah, just do that for now, I guess.
Is that you?
Can't tell anymore.
Shoot.
Yeah, so.
Hi everyone, welcome back to today's PEM conference. So I'm delighted to introduce Dr. Nisha Balan and Dr. Shri Raju, both consultant child and adolescent psychiatrists with the CAMS team here in Leicester. They're going to give a talk today on mental health presentations to the emergency department with some top tips for PEM clinicians. Thanks very much, Nisha. Nisha, we can see your presentation there, but I think you might be mute. There you go,
yes, yeah. I was on mute and the video was off. I need to share again. Sorry. I didn't realize you have to switch this on before you share. Here we go again. Let's give it another try. Where are we? Okay. Can you see the slide?
No, if you go back down to... Yeah, that's perfect.
Yeah, okay. So the topic of mental health presentations in the emergency department. I'm Dr. Nisha Balan, and I have my trainee, Dr. Shri Raju. I don't think you can see her yet. Sat with me. She'll do the second half, and I'll do the first half, if that's okay. We're happy to take questions towards the end, and do warn me if I'm speaking too fast or too low in volume.
No, the sound is perfect, Nisha. Yeah.
We work with the CAMS crisis team, and we have close links with the Leicester Royal Infirmary Emergency Department. The questions that I was asked to address, I'm not sure if you can see this clearly, but one of the questions was mental health presentations over the last 20 months, has there been changes? So I just thought I'll start off with what we already know about mental health presentations. Half of mental health disorders we know start before the age of 14, and almost 3/4 start before the age of 24 years. We know that in the past more than a decade, so to 2010 onwards, there's been an increase in the number of children presenting with suicide and self-harm to emergency departments. And we also know that suicide is the leading cause of death in men in this age group, under the age of 18 definitely, and girls as well. There's been a more drastic increase in girls with self-harm and suicide presentation over the last decade as well. Young people in their late teens, they have the highest rate of self-harm, and self-harm, as we know it, is the strongest risk factor that predicts death by suicide so far. Both suicide and self-harm have got similar kind of influencing factors. With regards to mental health and emotional well-being factors, we know that it's influenced by biological, psychological, social factors. So if you think about biological factors, the genetic predisposition, biological factors within the individual, within the family, for a child, definitely the support system, biopsychosocial factors also have an influence. And just think back on how COVID has impacted on that. Mental health difficulties we know are more common within children who have got special educational needs, looked after children who have been exposed to adverse childhood events like abuse, living in socioeconomic deprivation, etc. These factors do predispose to high risk. Under the age of 12, mental health or behavioral difficulties, what we notice, children, usually there's a difference in gender presentation, so boys present more. After puberty, we find that girls present more with emotional difficulties. We also know from the MCASH data that hanging and suffocation are becoming much more commonly reported now, and mental health difficulties in self-harm in children, these are strongly associated with socioeconomic deprivation. Moving on, what's happened with the COVID pandemic? If you have noticed this paper in the BMJ, August 2021, they took into account the evidence that's available. What they found is under the age of 18, there's very little surveys and surveillance that's being done to inform us of the impact of COVID on the emotional well-being and mental health of children. There's more that's done in adults. Perhaps the reason is, how interested will children be in completing these surveys. So they have kind of approached older teenagers and parents for children and teenagers both. What we know from this evidence is that there's varying reports. Some children have found that the lockdown and the COVID have actually resulted in them feeling a lot better initially, and then going back in after restrictions were lifted, supported their well-being. Whereas quite a lot of children went through a very difficult period. They presented with difficulties, especially if they have already had mental health difficulties. There was a worsening in the presentation and their ability to manage stress. Okay. But again, this information has been gathered not just from the UK. This is something that's been seen across the globe. So it's a multi-center research evidence that's been pulled together. They have looked into why there were some children who actually benefited from this, and they postulated this could be because children are stressed about going into school, and there's lots of demands and academic stresses with exams, etc., and bullying. When the lockdown was put into place, life became a lot more relaxed. There's no routines that you need to strictly follow. You don't have to force yourself out of bed to go into school if you don't enjoy that environment. And there's also a lot more closer relationship with parents being at home, not at work, and free time. So people did find that did help their emotional well-being initially. As it continued, the picture did change. What we know from the studies that have been pulled together is that screen time can have positive as well as negative impact. So some children found it easier to learn online, whereas children with special education needs did struggle with that. The negatives of screen time also came to the fore. There was more cyberbullying and potential for cybercrime. People were exposed to inappropriate videos, and if the children were not being monitored appropriately, they were doing things that were inappropriate with that age group and getting into unhelpful habits. Screen time, prolonged screen time, not sleeping, no routines, etc. had a huge impact as well. Lack of access to internet again resulted in children feeling this is not fair, and some of them being in deprivation did not help their well-being. COVID mental health, again there's a government report from the Wellbeing Surveillance, and that was done. The chapter 4 focuses on mental health for children. Poor well-being scores were reported with regards to happiness, life satisfaction, and feeling worthwhile by many of the young children and teenagers. There was increased anxiety, and I think you will be familiar with an increase in eating disorders or children with disordered eating presenting. It's just some facts and figures about what percentage increased from 2017 as compared to 2021 in age groups 11 to 16 and 17 to 19-year-olds. So yeah, the higher teens, there was a greater preponderance and an increase from there. Problems with sleep, 25% of 6 to 10-year-olds reported problems with sleep. What we found is that secondary school pupils were more vulnerable, especially children who have been in poverty, looked after children, and like I pointed out earlier, special educational needs, and children, girls in particular. What we also found is when there was a recovery with restrictions being lifted, this did not quite seem to be as prevalent in the secondary school children. The recovery was seen more in the primary school children. So that's what this is about. Conflict in family, parents who have their own mental health needs or physical health needs, BAME and health care worker families seem to be more vulnerable to the COVID-related stresses. Children had experienced fewer behavioral, emotional, and attentional difficulties since the lockdown restrictions were eased, but this was more seen in primary school children as compared to secondary school children. And it was this recovery was not seen in the SEND, special educational needs, and the low-income households and vulnerable households. Now, this NCMD report focused more on suicide in children. What we know during the period just before the lockdown, April 2019 and March 2020, 31st of March, is there was no kind of difference in within UK, the various regions with regards to rate of suicide or what groups, couldn't identify certain groups as being more vulnerable to suicide risk. 62% of the children who had suffered with suicide had suffered significant personal loss. Now, this personal loss does not mean loss by suicide only. It included loss of any sort. So if there has been a house move, again, that was classed under the loss. Loss of friendships, breakup of relationships, parental separation, divorce, etc. All that was included in this. So parental loss or loss of any kind does mean that children are more at risk of dying by suicide. Over 1/3 of children and young people reviewed by the included in this NCMD report had never been in contact with mental health services. So they've passed away by suicide, but have not had any sort of help, 1/3 or more of them. 16% of children who had died by suicide were identified to have a neurodevelopmental condition. So again, SEND children more at risk of mental health problems and also seem to be at risk of dying by suicide. Almost a quarter of the children who were reviewed had experienced bullying of some sort. Yeah, so being mindful that there are vulnerable children out there who are going on to complete suicide attempts. Suicide and COVID. Now, initial studies did suggest that there is an increase in suicide deaths as a result of the COVID pandemic. This is yet to be confirmed, yeah, and we are going to be looking through for more and more coroner's inquiries to be completed and following reports this year to kind of confirm if this is actually true. But this has been observed not just in the UK, again, internationally. So there's global, Japan, US, Bangladesh, and other countries reporting similar. Code studies, I think Young Minds as well, Samaritans who have been offering support over the phone lines, they have also reported that there has been an increase in number of calls received by children because they are experiencing thoughts of suicide and self-harm. So they have been asking for support specifically for thoughts of suicide and self-harm, and more so during the pandemic period. Okay. Potential reasons for this increase, vulnerability factors. Again, if you think back on this biopsychosocial strands, poverty, disparity, all adding to, social stresses, adding to psychological stresses. And if you are already at risk and there is a predisposition, it only increases chances. So this is a repetition of what we've already said, and we'll quickly move on from here. COVID-related, I think the last bit we need to focus on, the fact that because of COVID and the restrictions and the lockdown, etc., various services that were offering care had to kind of change the way they work. There was a period when there was a loss of contact with service providers. And again, the challenge between service providers like health linking up with schools when schools were off and people trying to make that link work. Those challenges just added to the amount of supportive networks that were available around the child and around the family to help them feel protected and manage the stresses in a more positive way. Okay. Now I'm familiar, because Shane kind of passed this on to me, that you use what is called the HEADS assessment to try and assess psychosocial factors influencing the child. All I wanted to make sure was you're aware of why we're doing it. So we're focusing on understanding the child's own mental health and mental state, and whether they are safe and experiencing any thoughts of suicide. And the HEADS helps us make that inquiry when we see the young person. Yeah, think about who are you living with, how are the parents, are they together, are they living separately, are they trying to manage during the period, are they in conflict? Has there been a loss because of COVID, loss because of other reasons? And how did they manage this stressor? The parents, how did they manage? How did the children manage the stressor? What is the educational status? Do they have special educational needs? Are they accessing education? Are they back into school, or are they struggling to go back into school? Are there any stresses in the school environment, bullying, etc.? Again, eating-related difficulties. Any hobbies or activities that could act as positive supports and positive ways of managing stresses, are they still able to access these? Drugs, we know there has been, again, many young people reporting increased use of alcohol, either because now they're at home, they've found it lying around, they've tried, or they've got into groups that are using substances outside of school and they've started using or have been using and it's got worse. So just being mindful to ask these questions. Children as young as 10 years maybe using. So yeah, just because they're too young, please do not skip that. And it does have a role to play with regards to managing your own emotional well-being. Sexuality, and again, this falls within the protected characteristics and vulnerable group, children with kind of diverse sexual identifications, so gender dysphoria, etc., they are much more vulnerable as compared to females. Okay. So moving on with regards to the BMJ article and thinking about what we think. The child is not alone, the child is surrounded by the family. We need to make sure that when we we assess for the needs not just of the child or the family, a brief kind of questionnaire. What are the family needs, and is that in any way feeding into the child's ability to manage? And then thinking about the child's support system. Is the school a support system? Are they still accessing it? Or is the school a stressor? And how do we then work with the school and the family and the parents? What studies tell us is if we can improve the relationship between school and family, the child feels a lot more safer. So any place where they feel safe, they feel like they belong, friendships can help them feel a sense of belonging, actually prevents recurrence and reattendances with thoughts of self-harm and suicide, and building on it. So the child is surrounded by these protective factors, which could also act as stressors if we are not mindful of what may be influencing the services and the family's support network. Okay. Moving on, just another slide to highlight that there are risk factors that could increase suicide, but then suicide is also influenced by emotional well-being and mental health factors. So being mindful of asking questions around these risk factors. Identifying risk factors will be to help improve the protective factors. So looking after a family's welfare, the parents' health needs actually improves the parents' well-being, and we have evidence from recent reports informing us that if the parents' well-being and parents' psychological state of being is good and they feel resilient, the children feel safer and the children's well-being also improves, and recurrence attendance to A&Es stops or reduces. Okay. The neighborhood, making sure the child feels like they belong to a safe neighborhood and there's a friendship circle and there's a family environment that they feel they have a sense of belonging within, and the school plays a huge role in that. So the reason we assess is so that we can influence and bring about more positive factors to improve resilience. Being mindful when you do this, that you are paying attention to the child's developmental age, functional and behavioral manifestations of that particular age. So the child may be 17, but if the child has got any learning difficulties or learning disabilities, we need to take that into account when we do the assessment. So communication and promoting ways in which you can communicate, ensuring that a child, if the child is presenting in a crisis, has got the time to, chill, relax, and separate themselves from a high stimulus environment into a much more calmer environment would be helpful. Children and adolescents, they may not look like they are experiencing distress, and they may not be able to communicate the distress that they experience, and hence giving them the time and giving them the language to communicate the distress, or the opportunity to identify with somebody who they can be open with is very important to facilitate communication. Yeah. Again, the last bit where you encourage resilience in all patients. So you might have a patient attending A&E because they've had a fall. Just a quick question: how are you doing? Have you had any other mental health problems or any other concerns that you're worried about? Are you experiencing difficulties? Are your parents all right? And how can we give them numbers to access support? Always helps improve resilience. Just a quick question and a quick, these are where you can access support. Does help. Long-term impact of COVID, we don't know. There's lots of uncertainties, and young children are not very good at managing uncertainties unless they have a support system around them that says, yeah, I know there are uncertainties, but we have a plan on how to manage this. So just being mindful of that. Yeah, we don't know when the lockdown's going to come back. We have into a plan B. What's going to happen next? No ideas. It may already increase anxiety in families who may have experienced COVID illness, deaths due to COVID, and how are the children going to manage that, etc. So just being mindful that we're going into a phase where things may be going back into the lockdown that we experienced previously. A follow-up study from the disaster Boulder Creek Dam collapse tells us that 2 years following the disaster, the persistence of PTSD symptoms, there was 32% increase in adolescents, in children and adolescents experiencing PTSD symptoms. What we know 17 years on, there was a fall in that, and it was 7% higher than usual. What I glean from this is it continues to remain high. So it's not like the stresses have gone away and the dam collapse didn't happen again, and therefore people are back to normal. There seems to be a trigger that has created a stressor and increased the presentation with emotional difficulties, that seems to be sustained. So maybe going forth for the next few years, we are to expect a high presentation to A&E. So whatever we can do to improve resilience, whether it is for children who are presenting with mental health problems or physical health problems, do try your best to do that. References, this is where I've picked up all the information from. Happy to share the slides. This is my part of the presentation, so thank you for listening. Hopefully I haven't taken up a long time, and I shall now pass on to Dr. Rajiv, who will do the next bit of the slides. Okay. I'm going to stop sharing this and bring on Dr. Rajiv's slides for you. Just bear with us, please. Are you able to see?
Yeah, we can see you clearly, but you're not screen sharing at the moment.
It's not sharing.
No.
Is that better? Are you able to see?
Yeah, we can see the slides. If you just want to maybe play from current slide. Yeah, that's perfect.
Hello everyone. This is the continuation to look at adolescent mental health. I think this is an overlap with what Dr. Balan has been talking, and this is the WHO numbers, the first two pointers here. So globally, 1 in 7 between the age 10 and 19 experience mental health disorder, and globally it is the 4th leading cause of death between the age 15 to 19. And within UK, the number of people experiencing mental health difficulties between the age 17 to 19, from 2017 to within 3 years, there has been an increase from 1 to 10 to 1 in 6. This is again an overlap of information. Dr. Barrett did talk about multifactorial reasons for why they are vulnerable in this age group, and why they could, adverse life conditions, make it difficult for them to cope, and they develop mental health difficulties. I put it here just to emphasize that the females are much more likely to develop depression purely because of hormonal reasons, which sensitizes their brain, thereby making it more vulnerable to the adverse event. So the ratio is about 2:1. So the nuances of adolescent mental health, so they don't present classically how the older adults present with depression and anxiety. They come with very indiscriminate kind of symptoms. We largely see physical symptoms as one of the presenting features, where they get largely GI symptoms, headaches, and sometimes even chronic fatigue kind of symptoms, which has an underlying mental health issues. As mentioned earlier, in more recent years, we've seen eating disorders, kind of presentation with restricted eating being one of the presentation. And by itself, it can be eating disorder, but there's been a complex mental health issue underlying that. Anxiety, again, is quite common in this age group, but it can also be just an overlay to what is happening in terms of their emotional difficulties or adverse life events, or it could be underlying a neurodevelopmental aspect. So all of this can look like a simple presentation, but could have a lot of complex mental health problems underlying. Obviously, it is going to affect their attendance, their academic performance, and in some young people, that is the only presentation we see, and the schools pick up from there, and there are complex mental health needs underlying these presentations. Substance misuse, as mentioned earlier, it's quite common in this age group, and it starts at very early, sometimes from the age of 10. Substance misuse sometimes covers up depression, anxiety, even psychosis in many cases, and a lot of neurodevelopmental developmentally affected kids sometimes use substance misuse as a way to cope. And behavioral problems are quite common, and it is quite hard to then unpick what is happening underneath. But it's really important to bear in mind that kids generally struggle to express their difficulties. And what you see is a lot of defiant behavior, anger, irritability, and there will be underlying mental health issues that needs to be thought about and screened for. This slide I've added purely because, from A&E point of view, I'm sure you're looking at increasing numbers of young people with mental health difficulties walking into A&E. And it's really important that there's a good practice that of trying to complete a mental capacity assessment for these young people when you feel they're medically ready to move on from A&E, or if you want them further assessed at a different place. It's really important to complete that, and if they are capacitous at the time you've assessed them, it's very safe practice to again include another responsible adult in your decision making. So that would be somebody from the young persons who can take on a role of carer, or it could be a parent, it could be a warden. Just make sure that you've had that conversation with the older person to make them aware that they are in A&E and they are ready to move on to a different place. Inform them, ensure that safety has been planned, and it's all the more important if you're making a decision to discharge them from there to home. Somebody is aware of that, because if somebody's made an attempt to end their life, evidence says that the next 7 days they're going to be very vulnerable, and it's very likely that they could repeat it, so they need a lot of monitoring around that time. So these are the criteria for why somebody is considered for a CAMS inpatient unit admission. Obviously, the first one is a bit obvious. If they've come with very high risk of suicide and unable to keep themselves safe with all the support that we could offer in the community, and if there's a very serious self-harm, those young people need to be considered for admission. And any enduring mental illness, that would be another criteria. If somebody is presenting with psychosis or bipolar kind of presentation, or extreme mood symptoms and eating disorder, if you go into the Marzipan guidelines, it will give you guidelines to what is the red rag rated within that presentation, which needs to be considered for admission. And sometimes a period of observation is needed and a treatment is needed in an inpatient setting, so that we can provide adequate monitoring by the specialist team. For that reason, we admit young people. Neurodevelopmental and learning disabled children, yes, they sometimes can be a risk to themselves and to others, and which can't be managed in the community, and for those reasons we do admit them. Clarification of the diagnosis, it's very common sometimes when there is a lot of complexity in their presentation and the history is not adding up, and we don't have any corroborative information coming from other sources. So for that reason, we need a period of assessment in a safe place, and that would be an unit. Yes, and sometimes within the eating disorder, I remember asking for few admissions within the pediatric unit for low body weight young people who need antipsychotic medication, so they need a cardiac monitoring. And for that reason, we have requested pediatric units to admit them for a period of time. These are nationally held beds, and I think we have about 15 units, NHS units throughout the country. So if each unit has about 10 to 20 beds, we are very limited nationally to only around 600 beds roughly. And there's unfortunately sometimes the kids have to move within the county when the availability of bed is not there, and we do provide that provision within LPT. So that's a very busy slide. I don't know how much of it you can see. This is a slide about rapid tranquilization, and it's more what is followed within the LPT guidelines. So this is for acutely disturbed young people between the age 12 to 18. So the main aim is to try and calm them and contain the situation and try and prevent any further escalation of the situation. Obviously, the non-drug approaches and de-escalation techniques will be tried initially, and that will be a good time to try and gather the notes and look at what is the current medication that young person is on, because they might go on to need some medication and you need that information. The first thing we try is promethazine, which is an antihistamine, and we give orally. Orally is always the first option that you try. Start with 25 milligrams. I may as well add it here that if some young people who do present to A&E come with agitation and they need some medication to go home with, we would prefer that they went home on promethazine. I think in the past we've seen some people being prescribed lorazepam, which hasn't been the right thing because they have come purely for the reason of getting lorazepam in future a couple of times. So promethazine would be the choice to send them home with just a couple of days before the camp service can assess them again. So obviously in a rapid tranquilization, you try it orally, and if it's not possible, you want to IM, you give 50 milligrams and then you wait. And if they're not tolerating the medication or if this hasn't worked, you move on to the next option. Sometimes because they are in A&E, you might have got an ECG, and that could help you with further management. And the table says that if they have a psychotic illness and established diagnosis, if they are not antipsychotic naive, they've had antipsychotic medication in the past, then you can consider oral risperidone. But if it is reasons that is not known and you don't have an ECG, it's a safe option to go to lorazepam. Again, offered orally 1 to 2 milligrams. And you can go maximum up to 4 milligrams in 24 hours. And if you can't, then you keep assessing the situation, 40 to 60 minutes. If things are not improving, then you could offer another dose and you could give an IM injection of lorazepam, always ensuring that you're not exceeding the 24 hours dosage. I think there's meant to be an arrow here from what I recall, because I think at that point in time, if they're not settling by 1 hour and you've already tried promethazine, already tried lorazepam, then it would be safe to consider haloperidol combination with promethazine. I will check that for you again because the table is not giving this clearly, and I'll probably send it as an email. But you would then start considering haloperidol 5 milligrams, and the research says that there's evidence to say if you give it as a combination with promethazine 25 milligrams, it's got good effectiveness, it acts quickly, and the sedation is quite prolonged as well. So that would be something you can try if lorazepam has not been helpful. Monitoring is the key within all of this, because it's really important that we monitor in the first hour. If the patient is mobile, then we would monitor them every 15 minutes, and if the patient is not mobile, every 5 minutes. And all the parameters, important vital parameters, blood pressure, heart rate, temperature, respiratory rate has to be monitored, and you'll have your pulse oximeter, so it gives you saturation as well. So ensure good monitoring in the first 1 hour, and after that first 1 hour, you still continue to monitor hourly. Some of the key aspects here is that these medications come with side effects of their own, and it's really important that you have some of this handy with you. If you've started a rapid tranquilization, make sure they have an anticholinergic medication handy. Make sure you have flumazenil in case you have to reverse the respiratory depression. Never mix 2 medications, because some of these protocols you have 2 IM medications, so everything should be loaded in different syringe. Ensure that it's given separately, and if you have the details of medication that patient is on, make sure that you don't use the medication from the same class of drugs, so you will avoid polypharmacy and causing more problems because secondary to medication. So that is the rapid tranquilization that is used in inpatient units within the LPT. I've added this ketamine because it was asked, we were asked to talk about it, and we don't use ketamine within LPT, especially in our CAM service. The expertise is not there. The CAM's inpatient units is purely run by mental health trained professionals, and some of the nurses and their healthcare support workers here are not trained for physical health, so it would be risky to use this. So in fact, I found this document from UHL. So Emergency Pediatrics has recommended ketamine, and I've just added the link here for your if you're interested in reading further. Oh, thereby we completed the presentation, and time to ask questions now.
That was a brilliant talk. Thank you very much to both of you. Really, really useful information. Can I just ask a quick question just about screening questions and how you risk assess children that are maybe suitable for outpatient follow-up versus admission? I know you touched on some risk factors for suicide, but are there any clear thresholds, I suppose, that would make you want to admit children overnight to the hospital versus discharge them home to a safe environment?
With regards to admitting children overnight, the NICE guidelines tell us quite clearly that children or people presenting under the age of 18 with self-harm or having attempted to kill themselves, overdose or otherwise, they are best admitted overnight so that they get a time to kind of de-stress or separate themselves from the stressful environment, whatever that was in the community, and then assess them the following morning. Gives us a better understanding of what have they what are they thinking about, having been given the chance to isolate themselves away from the stressful situation. Have they been able to contact supports? Have they been able to think about their actions, and are they still thinking that they should have gone through with what happened, or are they thinking, actually, we regret what we did and how much of weightage there is? It also gives us a chance to give the family the time out and reconsider whatever the situation is that they may identify as a stressor. But that's what the NICE says. However, we know that due to bed situations and the pressure on beds, we have been asked to kind of increase service provision and offer assessment during the nighttime period. So we do offer overnight assessments. So there's input from the all-age mental health team that assesses children who present with self-harm or overdose in A&E, whatever the time of the day or whatever the time of the night. There's also the crisis hub for children that assesses, that gives, I think we have 3 appointments available during the night time. So there's one at 9 p.m. in the night, there's another at 11 p.m. in the night, and then there's one at 2 o'clock in the morning or 3 in the morning that people can be referred to. And these referrals can come from A&E or from the community. So if there's anybody in the community that has called out the ambulance service or the emergency services like the police, etc., they can ring in to book an appointment with the hub. So we do offer overnight assessments for children. What are we looking for? What is it that happened? What are the stressful situations? And what are the supports available to the young person? Can we discharge this person safely back to the environment they've come from, if we are thinking of treating in the community rather than admitting? So if following the assessment we feel that yes, they have got parents who feel confident, they were not aware of what was going on, but now they feel confident they can keep a watch, they can be available to support, and they can supervise and make sure that things are not easily accessible. Dangerous items like medications are locked up, knives are put away, locked up if they need to be locked up. And ensure safety of the child, we do send them home with a referral to the crisis team, who picks up the following mornings. The crisis team works from 8 to 10, and after 10 o'clock, we do have the hub appointments, but we don't have an active crisis team on board. We come back to work at 8 in the morning, so if a referral is made to the crisis team at 8 o'clock, we then make sure we link in with whoever the patient is within 2 hours of having received the referral, and offer an appointment within 24 hours of having had that referral to us. And that's what we're looking for. Can this person be safe in the community for the 24-hour period, during which we have got the opportunity to go and see the patient? If that's not possible, and the patient is at risk, continues to be aggressive, continues to be psychotic, and there's no resolution of symptoms, then we are thinking about inpatient admission. If there's no immediate bed available, it might mean that the child who is in A&E may need to be moved to an LRI or an acute bed to wait for a bed while that becomes available, just because it's too risky to discharge them to the home. I'm going to pass you on to Dr. Raju to see if there's anything more you wanted to add.
No, I was just thinking, some young people do prefer to go back home because it's the safe place they recognize. They are with the people they want and they are in their own rooms. That's when we try and negotiate with the parents and get their understanding of what's their ability to communicate with this young person. If they've not communicated with each other for years, and nothing's going to change that night because it's going to be hard for the parents. And then they might still need to stay maybe a bit longer until they get assessed, because it wouldn't be safe to send someone who lacks ability to communicate with parents back to their house. So that's all I wanted to. Thank you.
That's great. Just one last very quick question. Just we're seeing obviously an explosion of admissions with eating disorders in the last 12, 18 months. One thing that's taught me is the ones that are admitted aren't your classical 13-year-old girl gymnast from an upper class background. They come in a huge variety of phenotypes. Do you think there's a lot of clinician bias in what's classified as an eating disorder? Is there a lot of maybe a barrier or a failure in some clinicians to recognise eating disorders because they often don't present in a classical sense, offering a clear history? It might be a bit ambiguous at the beginning. What's your experience with that and the kind of demographic or patients that you've seen in the last 12 months?
I think Dr. Raju, who has recently come from the eating disorder team, may be better at answering that question. But I do agree there are a number of children who do not present with typical features. They are very good at hiding the features and doing a lot of research online to check on how they can progress with their difficulties, and they aim to lose weight. And yes, it is a challenge sometimes to actually get all the information that ticks the boxes for eating disorders. And we have of late had a lot of disordered eating type of presentation where we've identified, yes, there is some diet restriction, but not a typical eating disorder diagnostic, not all the diagnostic criteria fulfilled. But Dr. Raju?
Yes, I think there's been a massive increase in the eating disorder kind of presentation, especially over the last 1 year. What we've noticed is, I think, what we call as avoidant and restrictive eating behavior, RFID kind of presentation, has increasingly come into light because of COVID. And this might be kids who have never been diagnosed with neurodevelopmental issues in the past. So there is a huge representation of autism kids within eating disorder. And these people have somehow survived with their limited diet until the COVID was thrown at them, sadly. And what they've had to do is restrict it further. So that's when the weight loss, that's when the anxiety and the difficulties have come to surface, when they've had to cope with added stress. So that is the presentation that we see more often. But the other aspects, I completely agree. I think it's just the classical presentation of a certain BMI walking into the A&E is not happening any longer, because I have increasingly sent a lot of people with BMI around 15. But what has happened is that weight loss is very significant in the period that we are assessing them for. If there is sort of 2 standard deviation reduction in their body weight, it doesn't matter what their body weight is. If it has happened in a rapid period of time, that would then be classed very significant. And they need a thorough assessment, physical assessment in A&E, children's A&E, for us to be able to then continue to treat them within the community. I think marzipan guidelines, I would suggest, is a very good document to look at. And if it's there in children's A&E, it would be a very good kind of reference point to go back to and see what is classed in red and what needs further assessment within your setup before they are sent to the eating disorders, I would say. And yes, I've seen a lot of boys now in this COVID scenario. We've had lots of boys coming into eating disorder as well. Somebody who could have survived with restricted eating in the community if they weren't pushed and cornered because of the COVID. So yeah, that's been a huge representation and change because of the COVID. I hope I answered your question. Was there anything else to that?
Yeah, no, that was perfect. Thank you very much.
Can I just quickly, Shane, add, I won't take long. When we do an assessment for children with eating disorders and we present it to A&E and we've requested physical health checks, just for the what we found with some of the pediatricians or when the physical health checks have been done, when the results have come back as normal, they've discharged them home with advice to eat. And the young people say, yes, of course we will eat. Just being mindful with eating disorders, they'll say they'll eat, but they might be eating a quarter of a biscuit and saying to you that I've eaten 2 biscuits if they've eaten quarters of 2 different biscuit pieces at some point in the day. So just being mindful that the information they give may not be accurate.
Yeah, take a careful history, but don't believe a word. That's really helpful. Thank you so much to both of you. Excellent talk, and it's really nice to see your point of view and how these children are managed and how they're presenting. We might just take a very quick 5-minute break before we'll have Michael Barrett coming on to talk about top PEM bangers of 2021. Back live in 5 minutes, okay? Thank you.
And there's no better time than Christmas to run through your top 10. Some of you might, groan at the thought of another top 10, but it is the time of year, so let's get on with it. I do think that there's plenty to like and loathe about top 10s of the medical literature. There certainly is a seductive power of the top 10. They're evidence-based medicine for non-evidence-based medicine people. And they're easy, just like Sunday morning. You can sit back, you can relax, and you can listen to someone else procrastinating subjectively about what they think are the top 10 papers in PEM. There's no equitor guidance, so nobody can call you out as being wrong in your methodology, which is always nice. And they're fun to chat and sometimes argue about. So I hope this reference to pop culture works. I was a fan of Top the Pops on TV, as it was one way I could regularly see a certain variety of culture beyond my home village in the west of Ireland when I was a child. It engaged another sense. This weekly music show played occasionally great musical gems. The odd American musician was seen on it, and a fair few duds lost the time. And part of the enjoyment was the anticipation and the moaning that ensues during or after a song that could only be loved by the artist's mother. Myself and my sisters, we all cringed together. And when you look at the content of the playlist, one was subject to the booking agent, the directors, and what was hot at the time. So I'm the director, and using the help of a few tools that I'll introduce you to, will soon impart on you the top 10. So, looking at the Paediatric Emergency Medicine literature to derive a top 10 for 2021 is almost like looking at the vast expanse of space with a powerful telescope to determine the top 10 brightest stars in 2021. So our region of space is Paediatric Emergency Medicine, which of course overlaps with general pediatrics, emergency medicine, orthopedics, and a number of other subspecialties. So I'm going to need a few tools to help me. So I looked to the medical literature to help me craft this talk. A 2016 Academic Emergency Medicine article provided me with a matrix of assessments that you can see in the background, going into design, ethics, importance, impact. I took one look at it and decided against using it. There was only one of me, and there was definitely over 360 pediatric emergency medicine papers from January to December 2021 that I needed to review, and there's only so much time in the day. but I need to assimilate data quickly. What's hot? What's not hot? So I decided to use bibliometrics. And bibliometrics is the statistical analysis of books, articles, or other publications. I've used it before for a publication, and I know what it can do and what it can't do, and what's separate from critical appraisal or systematic reviews. And I decided to use the Dimensions AI tool. The next thing I had to do was decide on ranking criteria. And in deciding the ranking criteria, I obviously want to be transparent and replicable. I want it to reflect the opinions of the most learned academics and those of us who just like to read, who just like to discuss interesting papers and perhaps use pieces of them in our department. So I equated citations during the year to purchase songs. So Bing Crosby is the artist who has sold the most amount of songs for his song White Christmas. Sorry, I blundered through that. And that was released in 1942. I also used the metric of most played songs or streamed songs. And the equivalent to this is a term called altmetrics. Altmetrics are measurements and qualitative data that are complementary to traditional citation-based metrics. They include, but are not limited to, peer reviews on the faculty of 1,000, citations on Wikipedia, in public policy documents, discussions on research blogs, mainstream media cover, bookmarks on reference managers like Mendeley, and mentions on social networks such as Twitter. I feel that that's equivalent to streamed songs. And in fact, if you're interested by the altmetrics idea and concept, there is a website of the same name which produces the top 100 every year. So in the last top 100, which of course was in 2020, it contained 97 articles that were relevant to COVID, and only 3 articles that were non-COVID. So we need to take that into consideration, and of course that was what was hot last year and continues to be this year. So in the first year of any young article's life, it's very much a popularity competition, with the most eye-catching, the strongest endorsed, or the truly most striking evidence relevant to the issues of the time grabbing the attention of the audience. Paediatric Emergency Medicine is now a mesh term in PubMed, and that was introduced into PubMed about 2014. This was after a request by a paediatric emergency medicine trainee based in Melbourne, Australia. And it allows for us, in part, to concentrate on our part of the vast expanse of the literature with greater focus. We use the Dimension search engine, and it allows us to track citations and altmetric scores and much, much more of the 5.5 million articles that were published and in the search engine for 2021, of which 3,441 were relevant to emergency medicine and 361 were through the lens of paediatric emergency medicine literature. And like any good gathering, and to keep everyone safe, I tried to remove any reference to COVID. But as you know, there is always the risk of an asymptomatic carrier that might slip in there unbeknownst. So here is the top 10. Coming in at number 10 is the Paediatric Emergency Research Network, a decade of global research and cooperation in paediatric emergency care. So this is a review article by Terry Klassen from the University of Manitoba. Terry Klassen, of course, is part of the PERC network, research network, the Trek Knowledge Translation Network in Canada, and of course a co-founder of PERN. And it's interesting that this network, and one of its very first study, was born out of the pandemic response with a retrospective case control study of H1N1 influenza risk factors across the globe. This article goes into PERN's potential. Its potential is to remove barriers to allow more research networks to join a study and to extend high-quality research to all 6 regions of the World Health Organization, with a focus on including sites from resource-poor areas and studying marginalized populations, to ensure that all children globally receive an outstanding evidence-based care. They detail a further aim to be established, to establish and to grow structures and processes to achieve these outcomes. All of these factors will increase the capacity for nimble responsiveness to the changing landscape in global paediatric emergency care. And I think this is quite well demonstrated by their most recent publication looking at COVID-19 infections globally. The movement of research-derived evidence into clinical practice by knowledge translation and the implementation science behind it is one of the main drivers of the PERN network. So they propose a model for international research in paediatric emergency care, and their vision is to expand capacity for global randomized controlled trials, deepen the focus on the implementation science, increasing attention to healthcare disparities, their origins, with a growing momentum towards equity, and expanding PERN's global reach to add sites and networks from resource-restricted regions. Number 9, how physicians manage medical uncertainty, a qualitative study and conceptual taxonomy. This paper struck a chord with me because I've been that person, perhaps a little less now than before. The background to it is medical uncertainty is a pervasive and important problem, but the strategies doctors use to manage it have not been described. Uncertainty, which is the conscious metacognitive awareness of ignorance, has numerous and primarily adversive psychological effects. These include thoughts and feelings of vulnerability and a propensity towards indecision and inaction. When I'm describing it to trainees, I often tell them when they're allowing their emotive response or uncertainties to override their logic is that they need to turn on their professional side. The objectives of this study is to explore the uncertainty management strategies used by doctors practicing in acute care hospitals, to organize these strategies within a conceptual taxonomy or classification system that then can further guide efforts to understand and improve physicians' awareness and tolerance of medical uncertainty. This was a qualitative study using individual in-depth interviews. 22 people were interviewed. There were 40-minute interviews each, and there was a large amount of experienced and inexperienced clinicians who were all in a major hospital. And this is what they derived. This figure shows physicians' uncertainty management strategies, a conceptual classification system. As we look from left to right, we're seeing the more commonly encountered situations of uncertainty with respect to management strategies. The blue arrow at the bottom is the direction that the classifications go with respect to curing that uncertainty or palliating that uncertainty. A major category of uncertainty is in red, and these are strategies which are ignorance-focused, that is, directed at reducing or curing medical uncertainty by decreasing the ignorance that constitutes its cause as a metacognitive state. The next most common state is uncertainty-focused, directed not at ignorance that represents the object of one's uncertainty, but at the higher order, conscious awareness of this ignorance that is necessary for uncertainty to exist as a metacognitive state. And the strategies that clinicians employ in yellow is maximizing attention, minimizing attention, disengaging from the uncertainty, and ordering uncertainty. As we move to response-focused strategies, which are directed at ignorance nor one's consciousness of it, but at one's own psychological response to uncertainty. So listening to yourself and withstanding those negative effects, cultivating virtues that can deal with that uncertainty internally, compartmentalizing the emotive responses and issues that arise internally, self-affirmation and self-forgiveness. Next is relationship-focused strategies, which are directed at, again, the negative outcomes. And you can do that by sharing the issue with colleagues and sharing them also with patients. I think this is an absolutely fantastic descriptive study and should be studied by all. And I think it's highly relevant to all clinicians, but certainly is highly relevant to clinicians during their training and also when they're dealing with colleagues and perhaps even in their pastoral roles when they're offering guidance and a shoulder to lean on with colleagues when they're dealing with uncertainty. Number 8, simulation in continuing professional development of academic emergency physicians. This is a Canadian study, and this study sought to characterize how simulation continued professional development is being used in Canada and what academic emergency physicians desire in such a program. The findings of this Canadian national survey of education and simulation, and it was done to address barriers to participation, to decide on content, and to determine the frequency of simulation for academic emergency physicians. I see this article as being helpful in the incentivizing and the development of faculty training or consultant training through simulation. Number 7, this is a clinical practice guideline. This is an 88-page document for the diagnosis and treatment of acute hematogenous osteomyelitis in children, and it was developed by the multidisciplinary panel associated with the Paediatric Infectious Disease Society. And it offers recommendations with respect to testing, imaging, and strategies with respect to clinical scenarios in relation to acute hematogenous osteomyelitis. So for instance, for testing, should we do a blood culture before the administration of antimicrobial therapy? The answer is, of course, yes. Should you do a CRP? They say yes on initial evaluation, and they also suggest against doing other inflammatory markers such as serum procalcitonin. Imaging studies, always plain radiographs in the first instance, and if more advanced imaging is required, you're going for your MRI over other modalities. And also clinical scenarios. For instance, should antibiotics be initiated before invasive diagnostic procedures, or can they be withheld until after these procedures are performed? And of course, they state, which most of us would agree with, well, all of us would agree with, that if the child is ill enough and has a rapidly progressive infection, we start empiric antimicrobial therapy immediately, rather than withholding antibiotics until invasive diagnostic procedures are performed. Number 6, examining parity amongst Black and Hispanic resident physicians. And this was from the Journal of General Internal Medicine. And this included Paediatric Emergency Medicine and medicine resident physicians. So the US physician workforce does not represent the racial or ethnic diversity of the population it serves. So the objectives of this study was to assess whether the proportion of US physician trainees of Black race and Hispanic ethnicity has changed over time, and then provide a conceptual projection of future trends. So it was a cross-sectional retrospective analysis based on 11 years of publicly available data paired with recent US Census populations. So at the beginning of the study, there was 86,000 people or residents to look at, and that increased to 103,000 people in 2017 to 2018. So the results were, amongst US residents, in the 20 largest specialities, no specialty represented either the Black or Hispanic populations in proportion comparable to the overall US population. Only a small number of specialities demonstrated statistically significant increases. And this project suggests the current efforts to promote diversity amongst resident physicians are insufficient. This is the asymptomatic carrier that I was talking about, because I don't think we'd be talking about this educational innovation if it were not for the COVID pandemic. This is from a very well-resourced centre with lots of SIM infrastructure and resources available. And its title is Educational Innovation, Hybrid In-Person and Virtual Simulation for Emergency Medicine Trainee, published in Academic Emergency Medicine Education and Training. So the primary objectives of this innovation were to allow for a limited number of learners to be at a sim centre for in-person simulation sessions and debriefing, and project the simulation sessions to an online audience unable to attend in person because of the reduced capacity of the sim centre, and provide online debriefing for the off-site and the online audience, facilitated by experienced emergency medicine faculty. So there was the sharing of video and audio with remote learners, allowing them to see and hear the entire simulation. And once the simulated scenario was completed, the screen share of the video was transitioned to share presentation slides utilised for the post-sim debriefing. The learner survey that backed up this paper demonstrated that there were high rates of satisfaction for the online observation and debriefing sessions. When I read through this paper, one thing that I felt that was not adequately explained by the study was the efficacy of teaching this way, on the rate of acquisition of the principal aims or learning objectives of the simulation, and the retention of that learning by the virtual group. For me, it comes with a little bit of a health warning, but we must be conscious that needs must, and safety of staff is priority in education. Number 4. So this was published by the REPREM group, which is the research group in Paediatric Emergency Medicine across Europe. Pediatric procedural sedation and analgesia in the emergency department, surveying current European practice. So the objectives of this study are to describe, obviously, the current pediatric procedural sedation and analgesia practice across European departments. REPREM is also a member of the PERN research group, as is the Peruki research group. And REPREM is a research network that includes physicians like medical directors, research directors, consultants, or directors of medical education who work in a European pediatric emergency department. So this study is the first to shed light on the pediatric sedation practice in European emergency departments and uncovers important gaps in several domains. So children were sedated by general practitioners in 82% of cases. Safety and monitoring guidelines were uncommon. were common, at 74%, but procedural checklists and capnography were less available. In 37% of sites, the entire staff performing procedural sedation and analgesia were certified in Paediatric Advanced Life Support, and Paediatric Emergency Medicine was board certified in just 3 of the 19 countries. So work needs to be done on sedation medication availability, safety, and training of staff to perform sedation. Nurse-directed triage protocols are required, and there is a desperate need to address staff shortage and lack of space, and also to have allied health professionals such as child head therapists and there's a potential for hypnosis in order to deal with the distress that children feel when they're having a painful procedure. Having just published an article in Peruki on pain management, there are common themes for improvement in both research networks. Number 3, and again, I don't think this would have been brought to the fore of our consciousness unless we had the COVID pandemic. So this is a review article, and it introduces the application of telehealth in Paediatric Emergency Medicine. So with the Paediatric Emergency Department as both the originating site and distant site. And they present obviously the barriers to adoption, implementation, sustaining a telehealth program, as well as strategies to overcome them. They discuss cost, finances, as well as policy considerations and implications. Lastly, they review strategies for the evaluation to assess program impact and, of course, to maintain and ensure sustainability. So there are lots of opportunities for telehealth within a complex web of interactions in paediatric emergency care. And obviously there's a responsibility to ensure that children with urgent and emergency conditions can access high quality care through telehealth programs. And that program needs to reinforce the core principle of advocating for children and supporting the patient's primary care medical home. The stage is set for technology applications to address health needs of children seeking emergency care, and telehealth is a critical tool to support and augment usual practice as we strive to provide high quality care and improve outcomes for paediatric patients seeking emergency care. We have not yet grasped it in our emergency department, but I believe it will be undertaken in some way in our emergency department in the near future, and it's food for thought. Number 2, an operational framework to study diagnostic errors in emergency departments, findings from a consensus panel. We've all been there at the mortality or morbidity meeting or post-event, just scratching our heads. Is it our mistake? How did that happen? Why did it happen? The objective of this study was to create an operational definition and framework to study diagnostic error in the emergency department setting. So diagnostic errors were defined as a divergence from evidence-based processes that increases the risk of poor outcomes despite the availability of sufficient information to provide a timely and accurate explanation of the patient's health problems. The definition and diagnostic framework can inform the development of measuring tools and strategies to study the epidemiology and interventions to improve emergency care diagnosis. This has already been utilised in at least 5 studies in 2021 after its publication, and researchers have used it for quality improvement, to allow for subjective case review to determine whether a delayed diagnosis has occurred for the following conditions, such as DKA, appendicitis, and neurological diseases. It also allows us to look at physician-reported issues that should be accounted for when designing interventions to improve ED diagnostic accuracy. And this is also being used to explore a model for improving patient feedback in diagnostics. here is our number one. So continued supervision for the common paediatric subspecialty in trustful professional activities may be needed following fellowship graduation. So you've done your fellowship or fellowships, you're at the top of the training ladder. There is nothing that you don't know. Confidence is riding high. The big job is lined up or you're in it. And can you take it easy? Can I just dial back a little? And the outcome of this paper is your bosses think that you can't. So this is a survey from North America with quite a high response rate, an 82% response rate across 802 program directors. And what they were asked is that question. Was there a need to continue professional development beyond fellowship? And they all need ongoing supervision post-fellowship graduation. And to me, this indicates the continuing necessity to develop faculty and a training program for the individual arriving post-fellowship, or the new consultants, or the incumbent consultants within your department. We have spoken as a department about developing a consultant continuous education program. However, it's only been realised in part, and it's another one for the future and food for thought. That quote is from famous futurist Alvin Toffler: "The illiterate of the 21st century will not be those who cannot read and write, but those who cannot learn, unlearn, and relearn." So I hope I've opened your eyes to the seductive appeal of an annual top 10 at Christmas. Some bangers in there, all right. There's some bangers in there, all right. And I'd leave you to decide which ones you read into in the future and which ones you leave by the wayside. So thank you to the organisers and the audience for coming to hear us chat about this. Next week I'll be presenting my top 10 goodbye songs, and I'm happy to take any questions. Thank you very much.
That was brilliant, Michael. Thanks very much for that. Really enlightening. I really enjoyed reading your first paper, your number one choice. I thought that was really interesting. Just in terms of the transition from PEM fellow to your senior trainee to consultancy posts, probably I imagine a lot of it is just you have to feel the weight of the decisions when you're a consultant, and that's hard to simulate when you're a senior trainee. But in terms of just that transition period when you're coming towards the end of your training, how can we prepare trainees better to slot into consultancy roles, focusing maybe more on the more management side of running an emergency department and having that oversight rather than the more clinical aspects?
Thanks, Shane. I think it's a couple of things, isn't it? It's the acknowledgement of the need to do that in the first instance, and then crafting a program of training that allows us to deal with the needs. There are some generalizable strategies that cross lots of specialities that you can translate to helping you to work as a consultant, generic consultant, no matter what your subspecialty is, that I think most trainees get exposed to. But the ones that are really important when you're starting off and transitioning in as a new consultant is, how does it work on the floor within your hospital, within your hospital group? And the only way you can get that exposure is by dedicated time, allowing you to be part of the management structures and how they deal with issues during your attachment to a department. So what would that translate to? So most emergency departments have business meetings and clinical group meetings on quite a regular basis, and senior trainees should be a part of that. Obviously, dedicated time to address the training needs of the senior trainees within any emergency department should be there, and it should be cognizant of the management role that can be quite scary, or because you don't know much about it when you're transitioning from a trainee to a consultant. So there's lots of different strategies there, Shane, but I think for me, this was formalized to a certain degree in my training by generic courses. But how I really learned about it was putting up my hand, going to the management meetings, talking to my consultant supervisor and mentor and saying, I need to know a little bit about this. And it's through that experiential route that I picked up most of what I needed to do. I appreciate not everybody is able to do that. So formalising that through the colleges would be important as well.
That's excellent. Just another quick question on the, say, I know you've a strong interest in research, but for the more casual PEM trainee who wants to keep up to date with relevant articles, in your first couple of slides you alluded to how you chose your top 10, and it just shows how overwhelming delving online reading can be in keeping up to date. But what kind of resources or Twitter accounts would you recommend people keep up to date with?
Wow, okay. Well, obviously Perukis every time, but I might be a little bit biased in that regard. Yeah, I think it's about credible researchers, and obviously there's fantastic folk who are talking today, the likes of Tom and Damian, who really not only point us in the direction of good publications, but also kind of are, the original thinkers around the issues that we're dealing with on a day-by-day basis, and how we can help people overcome those. And I think, they're really good people to follow. I kind of poke my nose in the literature quite regularly. So the RePrem group have got a really good resource called PEMdatabase.org. I think it was originally the brainchild of Ayta Shavit out of Israel. And what it does is it aggregates all of the most recent publications relevant to PEM as per their search criteria. And so when we're doing our journal club, I will often consult that, or indicate to the trainees that they should consult that in order to decide what to review for journal club, and offer them guidance in that regard. And then after that, I guess it's just what are your interests, the landscape is so massive now and so huge. I think it's for the individual to find out who are the lead academics or organisations or research groups within that field, and perhaps follow those as well. So there's too many options really it's nearly a talk in itself, isn't it? There's my advice.
That's great. Just another quick question, just on trainees who want to get involved in research in PEM. I know because people change jobs so frequently and they're balancing up their clinical and other training requirements, they tend to be limited to just retrospective chart reviews or performing a systematic review online themselves in their free time. But what advice would you give to trainees who want to get involved in research to boost up their CV, or just to learn more about the research process in itself?
Well, actually, I think I might have it here. I didn't write this book, but there is a book, I don't know, it's probably casting backwards, How to Succeed in Medical Research. And I don't consider myself at all, by any stretch of the imagination, a success in medical research, but I do love it. And I bought that book so that I could answer that question. And as I read through it, it's just very clear to me that just participation and putting up your hand is great. If you put up your hand to do something, complete it. There's no question too silly. If you say you're going to do something, do it and finish it. And yes, there is value in starting with case reports. There is value in doing retrospective studies if the question is thought to be original, or if you're answering a question on a very large scale, like through the Peruki research group. I think it's to go to the individual who's within the hospital, or identify them before you even start your attachment and say, listen, I'm interested. How can I engage with the ways by which I can participate in research and learn more about research? So there is no kind of quick tip there. They're all very common sense approaches. And I know that we're in a time of the digital era, and there's some fantastic resources out there. But actually, ever before there was that, they were great books. And I suggest going on Amazon and picking a book with a high star rating on how to do research, and it's always a good place to start if you're very uncertain. And then you know what questions to ask. You know, they're no longer unknown unknowns. You now have a credible knowledge base that you can ask the right questions in order to learn how to expand your research portfolio.
That's brilliant, Michael. Really, really enjoyable talk. Learned a lot there. And I'm sure everyone else did as well. Thank you very much for your time. Really appreciate that. We might take a break now until 2 o'clock, and at that time we'll have Dr. Anna Baverstock giving us a talk on civility, kindness in the workplace. So just about a 35-minute break, and we'll see you all back after lunch. Thank you.
Allows flows of up to 8 litres per minute. The 3 factors that you can control and the settings you can adjust are the litres per minute, which is the flow rate, the oxygen concentration, and the temperature of the humidification. If you wish to change this, you press the centre button until the display you want to change is flashing. You can then dial up the number that you require. It will go up to 8 because it's a low flow circuit at the moment. The initial one to start with is 5 litres per minute. We calculate that by going at 1 litre per kilo per minute. So in a 5 kilo baby, for example, it would be 5 litres per minute. In a 7 kilo baby, it would be 7 litres per minute. The lowest you can go is 5, so that means in a 3 kilo baby, for example, you would still start at 5. So it's 1 litre per kilo per minute with a minimum of 5. The maximum that we provide is 2 litres per kilo per minute, so an example in a 4 kilo baby would be a maximum of 8. This one will adjust our oxygen concentration, so we
calculator up. I'm assuming that you know how to do this. You must be more techie than me. So if you just put in menti.com and then put in the number, you can just put a few options into the questionnaire, which is what is kindness. And before I even start, I'd be really grateful if you could just do that, and all will become clear at the end. I'm just trying to make this a little bit of an interactive talk, because as I said to Shane, my preferred medium is a workshop with a flip chart, so I'm sort of learning new ways of doing this. Okay. Shane, would you be able to just put that link in the chat so people can then pop it in while I carry on as well? Would that be all right? Okay.
Yeah, I just do that now. Yeah, sorry.
Okay, no worries. That's okay, no worries, that's fine. All right. So while Shane's just doing that, I'll introduce myself. So I'm Anna Baverstock, I'm a paediatrician, and I've had a role over the last 5-6 years as lead for doctor wellbeing within my trust. Initially looking at junior doctors, and more recently looking at senior doctors. And then alongside that, have had an ongoing interest in kindness and civility, which has just come about probably over the last 3-4 years, and that's what I'm going to focus on today. So the talk was around kindness, civility and team culture. And I guess my aim for today is to see if I can bring you along, because I suspect many of you will think that kindness are the soft skills, it's fluffy and it's nice, and it's probably very associated with being a paediatrician. And we talk about it being the soft skills, but what I'm hoping is that by the end of it, we're going to recognise that actually kindness is brave, muscular and strong. It's not easy, and it's absolutely not a soft skill. It's part of a really important skill that we all need to do, but it can be really, really challenging at times. So just to start with, what is kindness? So let's go back to some definitions. So kindness, yes, it is being friendly, generous and considerate. I guess we'd all probably associate with that. But the reason I really like the word is that actually the origin of kindness comes back to kin, being of a kind, and it's very much linked to who we are. We're linked together within families, but also in present and across time. And there's that real sense of interdependence and connectedness. And we often talk about work families, don't we? I think particularly in an ED setting. And it's internationally recognised as well, and there are some really beautiful words associated with it. One of my favourites is from the African concept of Ubuntu, which is I am because we are. So Aristotle talks about kindness being helpfulness towards someone in need, not in return for anything, nor for the advantage of the helper himself, but for that person helped. But what we increasingly know about kindness and all the kindness research is that actually when we are kind to each other, we benefit as the giver as much as the receiver win. Now continue with some definitions. So compassion is the deep awareness of the suffering of another individual, so that, if you like, your empathy, coupled with the wish to relieve it. And clearly there's a really big overlap. So I've learnt lots about kindness, particularly in the last few months. And I'm really grateful to Professor Archibong, who came and spoke to one of our network meetings locally. She's from the University of Bradford. So I grew up with the golden rule. Now, the golden rule is to treat others how you would like to be treated. And I thought that was a pretty good rule in life, but actually it's completely wrong, because what we need to be thinking about is more of the platinum rule, which is to treat others how they wish to be treated. And how do we even begin to know that? We do a lot of assuming. We assume the golden rule a lot, but actually we need to ask. When Professor Archibong's make everyone a cup of tea, how you have your tea. If you're making everyone a hot drink, what do? You ask each other how you want to have your hot drink, and many people may not even want a hot drink. So that gets us some way there. And then I've recently finished Brené Brown's new book, Atlas of the Heart, which I would utterly recommend. And she just, again, blew me out of the water with empathy, because again, we often talk with empathy, don't we, of walking in someone else's shoes. there's a brilliant quote, and I don't know where it comes from, that if you walk a mile in someone else's shoes, you've got a mile away from them and you've stolen their shoes. Okay, you haven't had any insight in terms of what it's like from their point of view. So rather walking in your shoes, I need to learn how to listen to the story you tell about what it's like in your shoes and believe you even when it doesn't match my experiences. So wow, now we're beginning to get somewhere. Perhaps now also we're beginning to get to the reason why kindness is so difficult and compassion is so difficult. So I'm very aware that I'm talking today as a white heterosexual cisgender female, and I really recognise the privileges that entails, and I think particularly being a female in the paediatric specialty, I'm often in the majority in the room. But I am kind to myself, and the first rule about kindness in all of what I'm talking about today is we have to start with ourselves. So Maya Angelou has this beautiful quote, which is do the best you can until you know better. Then when you know better, do better. And you only know how to do better. So this is my invitation to you all. If you have a wince moment, if you could let me know, because actually I have learned so much from people reaching out and saying, actually, when you said this, did you realise it could be interpreted as that? So there we are. And I'd be, yes, looking forward to those conversations. So where do we start in terms of recognising that if we are in the majority, we really want to make sure that everyone in our team is able, we talk about bringing your whole self to work, well, you can only bring your whole self to work if it's safe. So we, as a member of our local multicultural network, we've just introduced the See Me First badges, which you can see in the top left of the screen, which were started in the Whittington in London. And so as a trainee ally, I call myself, I'm really interested can call out with compassion when we're getting things wrong. So it's not enough to not be a racist. We need to be that next step and really help having those conversations. And I think Yvonne Coghill's 7 A's of Authentic Allyship is a really, really fantastic place to start. So I would really recommend that as a starting point. You know, do we have the appetite to actually have those conversations? Can we ask those questions and be curious? Can we accept and acknowledge that there is a difficulty? Apologise, don't assume, and what action can we take? So I would really recommend that. And again, as a long-term supporter of the NHS Rainbow Badge, originally a concept that Mike Farquhar, one of the paediatricians in London, set up, thinking about how we can really advocate for all of our colleagues who may feel themselves coming from a minority background for whatever reason. So changing tack a little bit, there is a huge amount of emerging evidence around kindness in healthcare. And so I've picked out a few that I feel are kind of more pertinent to sort of those with a PEM interest. If you're kind to, if patients care that is kind, it lowers blood pressure. They have less perception of pain. So post-operatively, they often need less analgesia. Back pain is improved. And certainly when I did ED many moons ago, we were always encouraged not to be too to some of the patients who turned up as frequent attenders because they'll just keep coming back. Actually, the reverse is true. If people feel that they're listened to, have their care given in a compassionate way and really feel that their needs are met, then they're less likely to present to our emergency departments. We improve healing post-trauma, improves endocrine function. And I think the real key bit that underpins, we feel like we're being spoken to by someone who is being kind. If you're really interested, these two amazing individuals put all of the evidence around compassion and kindness and care into this amazing book called Compassionomics, which is the revolutionary scientific evidence that caring makes a difference. So if you're in a position to be able to start altering things, this is your kind of cost-benefit analysis. It's a fascinating, and again, I mentioned some of the things on the previous slide, so I won't go through these in detail. So my starting point for well-being is to think about self. And an analogy I've come up with is thinking about ourselves as a battery. So I'm sure you're all utterly aware of how much charge you have on your phone. And if you're listening on a device that's not plugged in, you're probably already running around and trying to plug it in. And during our busy shifts, we're very aware of when charge to get us home. But how aware are we of our own well-being charge? Because we all charge and drain at home and at work. And it's not enough to arrive at work fully charged and then be expected to come to the end of the shift with just the last tiny bit of energy left. Because actually, here's my challenge to you all. How do we make sure that the first patient of our shift and the last patient of our shift gets the same kind, compassionate care? Because if I'm the person that you see just before you clock off for the day, I'm not going to expect anything less. And what we know is that when we are recharged and we're running in the green zone, we clearly have enhanced colleague wellbeing, but actually we are able to produce safe, compassionate care that's of a high quality with less errors, that's good communication and less complaints. And the reason that Google and Microsoft and the big multi-tech companies are so interested in looking after their colleagues isn't really anything to do with compassionate care cost. And if you want to make yourself feel really, really jealous, just Google the kind of relaxation staff spaces that Apple and Google produce for their staff, and it's quite eye-watering. But this is very much what I'm talking about. So we recharge as individuals, teams and systems, and we clearly drain as individuals, teams and systems. And I think this was a huge concern 3 years ago pre-pandemic, and guess what? It hasn't got any better. And what we know is that if we only ever manage to hit recharge at the end of a holiday before we log onto the computer or start our next shift, then we're not going to be able to sustain that. And for so many of us, the things that we normally do to recharge just aren't necessarily available. Many of us haven't been on holidays, haven't had the family gatherings that we want to, particularly if we have family overseas. And we know that if we veer into the red zone, then we get the triads of burnout, which is compassion fatigue, which is overwhelming exhaustion, cynicism and detachment, and feelings of reduced effectiveness and accomplishment. And it's just really to reiterate that burnout is a system issue. It is very much a workplace issue rather than a lack of individual resilience. So if any of you are on Twitter, I'm sure you probably follow Simon Fleming, who's one of the orthopaedic registrars, and I've studied burnout for the last 5-6 years, and Simon came up with probably the best visual analogy to burnout that I've seen to date. If you have any others, please do let me know. So here we are, have a bit of a think. I wonder how you're all feeling right now in terms of numbers. Hopefully it's been a really good morning, you've had a nice lunch, you've probably had a bit of a break, and you're hopefully not going into the afternoon lull of about 3 o'clock sleepiness. I'm going to try and keep you entertained. So you're probably feeling quite good. But on an average shift, what's your range at work? What number do you start at? And what number do you go to? And when do you recognise when you're kind of falling down through the numbers? So if you want to print this off, stick it up somewhere, I'm sure Simon would be absolutely delighted. There was one that he did around hedgehog cakes, but it wasn't nearly as good and slightly perturbing. So there we are. What's your range at work? And absolutely, some of us might be having quite difficult times at home as well. And so we're not necessarily arriving at the beginning of the shift firing on all cylinders with number one. And I think we absolutely have to recognise that as well. So, kindness in teams. I'm just going to talk through some concepts. I'm really, really happy to answer some questions at the end. Sorry, I should have said that at the beginning. I'm not going to talk for a whole hour. I could talk for a whole day, but I'm not going to. So please do put some questions in the chat box or wherever you need to put the questions, because I'm really, really keen to have some discussion at the end. So the first thing to say around kindness in teams is that there are various different aspects. So the first thing to say is I'm a big, big fan of, again, this came from Mike Farquhar's work with the guys in St Thomas's in London. If you're hungry, angry, I'd add a late lonely, so I'd add an extra L. Hungry, angry, late lonely or tired, you need to take a break. Okay, how good are we at taking breaks? Right, the reason that the hand washing campaign took off so much within the NHS is that patients felt able to challenge us if we hadn't washed our hands. How can we get to the stage where patients are saying, I see that you haven't had your break and I want you to deliver safe, kind, compassionate care. I'd really like you to take a break and then come back and see me. Can we be honest with ourselves? One of the ideas I had, and if anyone is techie minded in the audience, is light. So we set our badge at the beginning of our shift, and we're in the green zone, and then it pops to amber and then to red if we haven't had our break and we haven't been able to reset it. I think that would be a really, really good visual way of saying, I've not had my break, I've gone into the red zone and I'm not forming a part. If anyone wants to take that on as a project, there's my gift to you. I don't have the text skill to do it, but I think it'd be really, really powerful because it's a visual way of saying around the breaks. If you haven't yet heard of the Learning from Excellence site, I'm sure you have, then I would absolutely recommend you check it out because there's a huge amount of evidence for learning from when things go well. Some of that is saying thank you and acknowledging when things go well, but some of that is in terms of thinking much more wider. So I will mention them a little bit more. So just want to introduce the concept of psychological safety. And again, I'm sure this is familiar to many. So I really like Amy Edmondson's work on it. She's written a brilliant book called The Fearless Organisation. She's done brilliant TED Talks, and she's done a lot of work within organisations in the States, including healthcare organisations. And at its heart, psychological safety is the belief that you won't be punished or humiliated for speaking up with ideas, questions, concerns, or mistakes, no matter where you are in the hierarchy of the organisation. And within a team, it's a shared belief held by members of the team that it's safe for interpersonal risk-taking, it's safe to have those conversations. It's safe if you're in a team and there are 10 of you and 9 people are really pushing for a certain decision and you have a bit of information that you feel really goes against that decision, it is safe to speak up within that setting. And Tim Clark, I think, goes a step further, which I think is really helpful thinking of this in terms of a learning environment for those of us who are at different stages of our medical career. So the very first stage of psychological safety is, am I included? Okay, and this absolutely comes down into all of those who, for whatever reason or other, may feel that they have less of a voice. But if you're not even included, then you're not going to feel safe. Speak up. Do you have learner safety? So I would hope that right now you're all sat nice and comfy, you're feeling pretty relaxed, and you're all feeling like you're hopefully taking some good learning points on. Okay. Some of you will be able to go to that next step, and you will want to have contributor safety. So you will ask a question, you will have some dialogue, and you will feel happy to do that. And some of you may even feel, and I welcome it, that you have challenger safety. If I said something that you're not sure about, or you want clarifying, or you disagree with, then you would, because I always find it really helpful to think about these 4 stages, particularly if 3 or 4 people have been very vocal and 4 or 5 people haven't been very vocal. How can we enable everyone to speak up? So much is written about inclusion, and there are loads and loads of really brilliant visual representations. I really like this one. You know, equality isn't so great if actually all it does is level everyone to the same level, but actually you still aren't able to do what you want to do. Equity in some, it goes a little bit further, but actually can we not liberate or actually include? And I found this one just recently on, another talk around thinking about more cultural inclusion. So diversity is a fact, equity is a choice, inclusion is an action, and belonging is the outcome. So here's my challenge to us all. Can we welcome the diversity that is in our organisations? Can we enable better equity? And can we enable all our colleagues to feel included? Because the outcome of that will be belonging and improved performance. And there's lots of brilliant data around now that the more diverse an organisation, the better we are. So learner. So are we able to ask? Are we able to ask those questions? So there's all sorts of examples, but I did these slides during the Olympics, and Charlotte Worthington was the first woman to land a 360-degree backflip on a BMX in a competition on her 2nd attempt. So she was absolutely at that kind of learner safety, wasn't she? She didn't get it right the first time. She kind of knew that she'd learned enough to get on with it, and she wanted to have another go the second time round. So actually, are we able to establish some learner safety? So contributor. So I want to imagine all of us are on the call, are sat around, you know, those lovely old heady days of being in a conference room. We were all sat, and instead of me parroting on, we were having a discussion around how we can embrace kindness and civility. Now, the success for me of that was to be able to enable everyone to speak up and contribute. Because we all have a puddle of information and a puddle of ideas around kindness and civility. And actually, if we were all able to put it into what we call a shared pool of meaning in the middle, it would then mean we would have a really rich discussion. And some of us would be able to contribute verbally, some might be much happier putting it on a post-it note and put it on a flip chart. So thinking about a pool of shared meaning in terms of everyone being able to contribute and put those ideas that perhaps we haven't otherwise thought of. And again, this comes from a brilliant book called Crucial Conversations. So challenge of safety. So again, right at the top of the challenge of safety. And I hold this in my mind, is that clear is kind and unclear is unkind. So again, another quote from Brené Brown. In terms of actually, it's kind to be honest. It's not kind to not say that thing. So can we call it out with kindness? So that leads into this. So we're not very good at having brave feedback conversations. It's a topic for an entirely different day, but I wonder how many of us have actually thought about and had training about how we receive feedback. I certainly, as an educator, have had many, many sessions around how to give feedback. I've had many sessions about how to frame feedback properly, how to ensure that I'm delivering feedback in a way that can be heard. It would be even better if, when we work together, and how we can then improve moving forward. It requires time, and it requires us to really lean into what's triggering us in terms of sometimes the truth about the feedback, the relationship around the people that are delivering it, and sometimes our identity. I'm sure we've all sadly received feedback that has been very challenging and been delivered without very much support. These are my descriptors of Kim's work. So I call this stab in the front, and we know when you've been stabbed in the front, it feels really affronted. It triggers a bit of a fight and flight response, and all you want to do is run away. But I'm sure many of us have also had feedback which has kind of been sugar-coated. So the feedback where you might say, the trainee might come and say, oh, Anna, it's really difficult sometimes in teaching sessions with you because we can't get a word in edgeways. But actually, we really enjoy your enthusiasm and it's really great, so don't worry too much. So you're then sugarcoating that, you're dimming it down, dimming down the really important things and actually not then able to have that conversation. And actually, arguably, so the rule is if you talk about someone, it's fine to talk about someone, but then who's then going to have that if you're doing a stabbing them in front? You're certainly not challenging them directly and you're not caring personally. And you're also setting up a culture around it's okay to talk about people and nothing's going to happen. So thinking about how we feedback, we all know, and again from the learning from excellence and data, can we really ensure that we give lots of really good positive feedback? Relationships work better when there's 5 appreciative statements for every 1 developmental statement, but actually can we give feedback in a really brave, kind way? What's holding us back giving a colleague a piece of feedback? And again, like I said at the top of this call, if something people are doing or saying is giving you what's called wince moments, are you able to then share that? Because otherwise it will create a bit of a disconnection in your ongoing conversations. So I hope by now you haven't picked up on the fact that kindness is all about having really nice conversations and just avoiding the issues. Because again, I think sometimes what we do is that we're so worried about offending people that we end up creating artificial harmony. So that occurs when you all sit in a meeting and everyone agrees with each other that the best way forward is to go to that, and then everyone comes out of the meeting and then forms their little factions in terms of, well, I'm not going to do that because of this, that and the other. So you've created artificial harmony without actually having the brave conversation. But neither is it helpful to have personal attacks. And I do think, particularly in the social media world, we've lost some of the subtleties sometimes around having a really good, constructive conversation around something that we disagree on, that we can both lean into and learn from. We tend to be quite black and white in our thinking, and how can we expand that and have good areas of grey? So I really do believe that there is an ideal conflict point between which is constructive rather than destructive. And again, there's lots written by Lencioni in terms of his conflict continuum, which I really like. And for me, it's, can I be braver rather than trying to, because it's much more comfortable sitting within so-called artificial harmony. Okay, so I'm just going to read out a scenario. Where have you been? Glared the consultant as the night junior doctor arrived late to get here early to ensure we have good communication and you get set up. Get a move on, we're all going to be waiting. We've all been waiting. We're going to be starting late, and that means that everyone's going to be leaving late. Versus, gosh, you look tired. Busy night, said the consultant as the junior doctor arrived late to hand over. Sit down, let's have a cup of tea and some NHS toast, and we'll start handover when we're all ready. So my question to you is, which handover would you rather be sat in as a witness, and which handover would you rather be sat in as a junior doctor in terms of patient care, quality and safety? And I think we've to that. So I want to imagine there are 10 of us in the room, and I've just been unbelievably rude to Shane, and everyone has had that internal wince moment and gone, oh my goodness me, can you believe you? What happens when that really rude? So 80. Oh. Sally, I think you need to mute yourself. So 80% of the time, Shane's going to lose some time worrying about that rudeness. 40% of the time, he's going to reduce his quality of his work, because actually he's going to be just so worried, and his cognitive ability is going to be taken up by the fact that I've just been really rude. He's going to be kind of replaying the previous 2-3 hours trying to work out what's happened and what he's done. Guess what? As soon as that clinical scenario, so if we're in a resus situation, for example, as soon as that clinical scenario has finished, he's going to be out the door and not wanting to be working with me. And potentially, he's going to take it out on other people. But here's where it starts getting really, really scary. Everyone who has witnessed me being rude to Shane will also potentially be affected. So if there's a room of 10 of us and we're all in a resus, 20% of you, so 2 or 3, are going to reduce your performance because you're going to be so worried about what I've just said. And 50%, so I've just effectively wiped out half my team, because half of you are going to be less keen to help me because of the fact that I've just been really rude. If this data is new to you, I would massively recommend looking at the Civility Saves Lives website. Chris Turner, an ED consultant in Coventry, does a brilliant TED talk around when the red mist descends, amongst other talks. And I would really recommend that you check it out. There have been, so the beautiful thing about sim scenarios, so in sim training, is that you can often video them and you can then analyse behaviour and performance and decision making. And so there is a real increase in looking at rude behaviour and incivility within sim. So if less conversation, less good decision making, and it also has an impact. So it had an impact on communication, but also procedural and performance as well. Delighted to report that they've also started doing some studies around gratitude, and actually just saying thank you within a resuscitation scenario can increase communication and improve performance. And just one more example. This is a little bit stereotypical, and I'm sure would be the same way around, but this is just how they did the study. So rude surgeons impair anaesthetic performance. So again, sim scenario of looking after a patient in theatre who identify when they were working with the polite surgeon and the rude surgeon, but the anaesthetist did not feel it had an impact on their ability to manage the patient. They didn't feel that their performance when they self-rated was affected. However, when their performance was measured, 91% of anaesthetists performed at the expected level when exposed to the polite surgeon, and 63% did perform to the correct level when exposed to the rude surgeon. So the really important thing for me is we don't always have insight into the impact of someone's behaviour on us, which I think is quite interesting. Again, getting your message across by email or phone. We overestimate our ability to interpret emails. We think we get 90% of the subtle meaning, whereas we probably only understand 56%. If we pick up the phone, it's a bit better, 75%. Clearly, face-to-face is even better. We think it's really interesting. So I did this session to our trauma and orthopaedic department just recently, and the thing that came up on the pre-workshop questionnaire they were really interested in was a discussion around banter. Now, if there are two of you in the room and no one is listening and you're having friendly banter, then you're probably very safe in terms of you're not intending to hurt anyone. Okay. Where you cross the line is when you inadvertently, other people are listening who perhaps don't understand the context of the friendly banter or are offended by it because of differences in terms of ethnicity or culture or whatever. And if they don't share that with you, then you become ignorant to that. So if you're making a joke with a colleague and everyone's laughing, bar 2 or 3 people, you're not going to know that. And then there's the more malicious banter, which arguably you're not necessarily self-aware at, but the people in the room are more aware of. So again, I absolutely don't want to make our hospital that we're using humour as a way of being of including everyone and enabling us all to feel included rather than us. So if you want to use banter, the safest form of banter is to make yourself the butt of the joke. And then you get a bit offended laughs, but you're the only one that gets offended. I think I'll probably, well, yes, okay. So again, this probably just hammers home the point a little bit. Intent versus impact. So I think the important thing out of this is that everyone is capable of having a mean moment. We all have bad days. Hold that thought, and we will come to that a little bit later in the talk. But bullying is a more repetitive process. There is an imbalance of power, and there is more of an intent around it. And this talk isn't particularly about bullying, but I just wanted to kind of go those things. And again, teasing a little bit like banter is okay as long as everyone's having fun and no one's getting hurt. But how do you know that? Annual update. So I delivered 11 workshops through the year. So we were able to map data through the year. We were able to increase awareness of the link between incivility and patient safety from a baseline of 65% up to 100%. And we were overall able to reduce the reports of incivility from 73% down to 50%. The really important thing to say about that, though, is that's because we were able to monitor it over a year. But what we have absolutely done when we've done just a one-stop workshop within teams is we have actually increased incivility, because I think what we do is increase awareness about it rather than the workshop causes incivility. But it did create a bit of a heart sink moment when I started getting the data and had to try and justify to everyone why I was making incivility worse. That's the beauty of being able to map it over time, as it then did really reassuringly come back down again. So just a little word of warning if you want to map it out. We published a few posters, and actually the maternity projects being written up at the moment. So 2 midwives are completely delighted because they've got their first publication out of it. Around trying to change culture out there. So if you are doing some projects, measure. So we're beginning to see that post-workshop, we're hoping that we have now got an increased ability, and a bit that the midwives particularly liked was the active bystander approach, which I will just talk through. I just want to give a bit of a plug, because I see that this has come out really recently. So the College of Emergency Medicine has launched an anti-bullying campaign to challenge toxic behaviour in emergency departments. Respect ED do. It is absolutely fine to delegate. Is there someone that you are able to speak to about the behaviour so that they can then have that conversation? You don't have to necessarily speak to a colleague there and then, you can delay. If it's happening within a resus scenario, can you distract? Can you say a general term in terms of, I appreciate everyone's getting a bit louder now, I'm finding it really hard to concentrate, can we just focus on what's at hand? Okay. So if you're interested, this is the bit that I think is the kind of magic bit. This is the bit that worked really well in maternity. So Jerry Hickson and colleagues at Vanderbilt University in the States basically devised this cup of coffee conversation. And this is if an incivility is reported to you, but it also works just as well if you've witnessed that incivility, can you be an active bystander? And your aim in being an active bystander is to care, by part of the chat around the. And I'd like to share some information that I've just had from a recent conversation that you've just had with Shane. But before I do, I just wanted to check how you were. And I just wanted to let you know that after your conversation, Shane was left feeling really upset, Guardians. So I'm aware that I don't have much time. I'm just going to click through this. So the big pushback I often get is, I don't have time. It's all very well, His Holiness the Dalai Lama saying, be kind whenever it's possible, it's always possible, but I just don't have time. So again, from the Compassionomics book, when they studied the difference between a consultation that was done in a kind, compassionate way and a consultation, at a minimum, it takes 40 seconds to just check in and be that bit more kind and compassionate. So I guess there's my question. And I know EDs are busy, so it may be that on some of these days you don't have 40 seconds times however, but actually, on principle, do we have 40 seconds? I'm going to leave that with you. So I've talked about that. Just a little plug for the Learning for Excellence. There's some really, really lovely things around appreciation, which are really important and really lovely, and that can be embedded. And if you haven't already got some sort of going home checklist up somewhere in your emergency departments and in your coffee rooms, that there are loads available. So before we finish, I'm just going to invite everyone just to take a moment, because it's kind of 2:45 and we're sort of getting to that time of the afternoon where we probably just need to sort of take a bit of a relax. So if you're able to, if you don't want to do this, just breathe normally, but otherwise you can follow my instructions. If you are able to uncross your legs and just sit away from the back of your chair, we're just going to take a strategy breath. The army call this a strategic breath, I call it a square breath. So we're just going to breathe in, 2, 3, 4, hold, 2, 3, 4, breathe out, 2, 3, 4, and hold, 2, 3, 4. The reason I put this up there is if someone's really shouting and really angry at me, then one of the things I will often do while working out what to do is just to take a few calm strategy breaths. It takes you out of fight and flight and back into soothe. It's also a top tip if you're switching on the computer or you're waiting for it to load or you've got the wheel of doom or something awful's happening, you can just do a few really nice calm strategy breaths as you go around your screen as well. You feel so much better for it and it works just as quickly. So final thoughts. Remember the platinum rule. Remember, it's not about walking in someone else's shoes because all you do is steal their shoes and you're a mile away. My favourite thing, if I could capture this in feedback, I would. What's your theme tune? So I think I got this from Chris Turner. What's the tune that plays when you walk into a clinical situation? What's the theme tune that plays when someone sees that they're on the rota with you? And how can you ensure that you're that person that people want to work with because you're kind and you're respectful and you listen to them? Can we be brave in conversations? And what would be utterly lovely is, who are you going to thank today when you're on a study day today? So the next time you're at work, I want everyone to actively look out for someone that they're just really grateful for, and then send them a thank you email, a thank you text, or even better, a thank you card. So as I said at the top of this call, kindness is our superpower, but as Uncle Ben in Spider-Man says, with great power comes great responsibility. So whilst civility is a gateway to excellence and flourishing, much as rudeness is a gateway to bullying or hostile behaviour. So I'm going to stop sharing my screen. And I'm really going to answer any questions.
Thanks, Anna. That was brilliant. Really enjoyable talk as always. I just have a quick question. Can you give an example maybe of when you or somebody else played the role of an active bystander and when it led to a positive outcome or it helped to shine a light on someone's behaviour?
Yeah, so I can give a really recent example. Actually, I was working with a white male colleague who was in a Teams. We were in a Teams meeting. And he was talking, we were talking about the importance of ensuring that we really think about cultural diversity and ethnicity, and he kept talking about coloured people. And I could see that there were colleagues on the call who were actively wincing. Now, I wasn't brave enough to call it out there and then, but what I did afterwards is that and a couple of colleagues afterwards came up to me and said that they felt really, really upset. And so I said that I was going to have a conversation, but I didn't feel like I could call it out there and then. So it was sorted out by the fact that I could see it, but actually I'd have had it anyway. So I went up to him afterwards and I just said, was he aware of the impact of when he said the word colour that people were disengaging? And he said, I did see a couple of people shy away, and he said, and I didn't know why. He said, so thank you very much for calling it out and calling me out and talking about it. And I guess that's the bit that I've just been on a talk with Partha Carr, who talks brilliantly about this, but it just reminded me of, can we assume that someone doesn't know? Unless you know better, you can't do better. Can you assume that someone doesn't know? And although it felt quite scary having that conversation, had I not had that conversation, I'd have beaten myself up about it so much more, because you'd be still thinking, I wish I'd said something. And the reassurance it gave my colleagues who also saw it but didn't feel able to was huge. So that's just the one that comes to mind.
Really good example. Thanks, Anna. Just wondering more generally if you have any tips on just keeping morale up in workplaces. You find just coming up to changeover when people have been maybe in the same group for a while and the novelty wears off and people struggle just to keep the morale boost towards the end of rotation, especially coming into the winter. Bearing in mind people have different stressors in their background. And any little tips or tricks just on the shop floor, things you might do?
So I am a big believer in informal little morale boosters. So Heidi Edmondson talks really, really beautifully around some of the things that she's done at Whittington Health with the kind of 10 to 10 or the 11 o'clock kind of sort of check-in. And I think that can be really, really helpful. Humour, I think, is really important. There are some things that you can be generically funny over. So there's some really, really good little team builders that you can do that create some humour. Sometimes purely just having a tea trolley, so a little mobile tea trolley and everyone just coming around and having a bit of a check-in and a bit of a stop. It's really thinking about those little moments of connection. The important thing is to try and keep it genuine and fun and real and not tokenistic. So within the first wave of COVID, we were trying to do this check-in and check-out process, which people were talking about a lot. And in the wrong hands, that can seem really, really awkward. So I certainly sat in a Teams call where a clinical director went, right, apparently I'm meant to check everyone in, so how is everyone? And it just kind of like, oh, please don't say that. So it's about those sorts of things. So little example we do in PEDS, again, ideas come from our trainees. So one of our trainees, Sarah Arthur, came up with Friday. So every Friday we have lunch together. There is no set agenda on the teaching. The hot week consultants bring in a cake or go to M&S and quickly buy a cake. And we just have downtime and laughter. And what's so important at that is that often that's when you have all of those shared little moments. So we've celebrated pregnancies and births and marriages and all weddings and all sorts of things. But it's also just that fun. And don't underestimate the power that those little moments of connection can bring.
Some really good tips there. I heard you mention a couple of resources like Learning from Excellence and a couple of nice books which I'll add to my list by Kim Scott, Amy Edmondson on psychological safety. Just on any other resources that you think if people are interested in this talk might want to read up on in their own time, what you might point them towards?
Yeah, so I think there is emerging literature around sort of incivility and kindness within settings. So I'll try and tweet out some links as well, or I can share them with you, Shane, as well. There's a couple of so Michael West, couldn't remember his surname, but has written a fantastic book called Compassionate Leadership. I did have a slide on it. I flicked over because I was just aware that I wanted to leave some time for questions. Again, he's written a huge amount. So he's from the King's Fund, an organisational psychologist from the King's Fund. He's written a huge amount around the need for compassionate leadership and the importance of it, and that would be a really, really good starting point as well.
Excellent, that's brilliant. There's no more questions in the chat box, but I think we've covered an awful lot there. That was really enjoyable, Anna. Thanks very much.
No worries, that's fine. So the only other thing is, if I change the slide on Mentimeter, I wonder if everyone can just to Mentimeter and answer the question of what do you think kindness is now?
Yeah, I'll put it in the chat box there. So
brilliant.
Everyone, if
and then what I'll probably do is I'll gather up the word clouds.
Okay, so everyone, if you're online, just click on the link in the chat.
So what I can do is I can share, if you're happy, I can share my screen again.
Yeah, go for it.
While you're sorry, hang on, I can't do two things at once. This was what you said to start with.
Yeah, there you go.
So understanding, empathy, compassion, care, and being nice. Friendly, life-saving, smile. You kind of got it anyway. You didn't really need much thought. So that's what you said to start with. And then let's just see, give people a couple more minutes to what. That's the second one. So there's a little bit more bravery in there as well, calling it out. Oh, it's live, it's changing live. There you go. Okay, so brilliant. Keep popping your answers in, that's great.
And just another quick question, Anna. I think paediatricians are known for their humility, and we think of ourselves as being quite good communicators. Do you think we are actually, that's a learned process we improve on over the course of our career? Or do you think we're any different to other specialties? Maybe we think we are, but we're not. I don't know.
Yeah, so great question. So actually, really interestingly, so where this work stemmed from was I tweeted out about, I think it's about 3 years ago now, that the orthopods have hammer it out, the surgeons have cut it out, the obs and gynae team have push it out. What should our paediatric hashtag be for calling out bullying? Expecting a really light-hearted debate around, share nicely or play nicely or let's talk to each other. And what people did is they and it was really humbling. So they used my tweet and they quote tweeted it with a thread of the undermining and the bullying that they had been exposed to within the paediatric setting. So I don't think for a minute that we don't have a difficulty with undermining and bullying behaviour in paediatrics. Yes, absolutely, we are in general kinds of compassionate, really good communicators, but there is a dark side to being a good communicator, and that you can undermine and bullying with a smile on your face in a way that is really, really toxic and challenging. And so I was really grateful for Camilla Kingdom, who was the vice president at then, is also now our president. And she and I had a conversation saying we really needed to do something about this. So we used a workshop at the college meeting, and we then wrote a paper on bullying and undermining. And again, I'll look it out. I'm very happy to share. And that was around certain scenarios, but particularly in paediatrics. So I think we have our own version of bullying and undermining, and I think actually it's different than perhaps the more stereotypical orthopaedic way, which I think is in some ways harder. So I certainly have been exposed to some really challenging undermining behaviour. My response has been to apologise and then walk away and think, hang on a minute, why am I apologising? Whereas if you're, undermined in a sort of more of a, you've done bad or a very black and white way, then sometimes it's an easier thing to take away. So I think we should absolutely lean into the fact that we tend to be good communicators. We often really like working with children and families and are good at adapting our communication style for our patients and our families. But we need to recognise that there's much we can do within our teams as well.
Excellent. Thanks very much. That's some lovely tips there. Do you want to go back to the word cloud?
I've got there one more time. Yeah. So there we are. So I've got calling it out, bravery. So thank you. So I will compare the two. But no, thanks for that. It's just something that I've started to try and do, because normally before I do a workshop, that's what I do. I get everyone to write it down on a post-it note as a kind of before and after. Brilliant.
That's lovely. And if people want to find out more information, they can probably find you on Twitter.
Or email me, because actually this is, I'm really interested in continuing to have these conversations, because I think there's a lot of really good work happening, but there's much more that we can be doing.
Excellent. That's brilliant, Anna. We've learned a lot today. I certainly have. Thank you for your time. Really appreciate that.
No worries. It's lovely speaking.
Great. Thank you. Have a nice day. So I think now we can move to our final speaker of the day, Dr. Damian Roland, consultant paediatrician, consultant paediatric emergency consultant in Leicester Royal Infirmary. He's our clinical lead here, heavily involved with Peruvian research. and a huge influence within PEM and research. Damian, are you online if you're happy to share your screen?
Right, can you see that? And is that full screen?
Yeah, if you just click play slide, but it looks great. Yeah, we can hear you.
Yeah. Why is it not moving on? Let's... Oh, sorry, my computer has... right, is that moving backwards and forwards?
No.
Have you got a different slide now?
No.
Oh, that is disappointing, isn't it? Let's try again. Is that working now?
Yeah, that's perfect.
Okay, brilliant. Sorry about that. Right, good afternoon, everyone. Thank you very much for joining. So, I've already been contacted by people concerned about the title for this particular talk. And so, first up, I will, I suppose, explain that there is no intention of this talk to be saying that no treatments in PEM are necessary. Clearly, if you're a diabetic, you need insulin. Clearly, if you're hypoglycemic, you need glucose. And I've done a slightly provocative title to garnish attention rather than say that's what I truly believe. Having said that, over the last year, I've given a number of talks where a common theme has started to come forward. And I'm going to share some of those themes. Apologies to those of you who have seen me present before. Well, it's not really an apology. I want to keep moving forward a debate on some constancies that we have excuse me, in paediatric emergency medicine practice. And this talk is also because there have been a couple of studies this year which I think have really reinforced the theme that I would like to talk on. And that is of what is treatment and when is it effective? And I think that's a really important question. And a good example of that is our current situation, for example, with bronchiolitis, whether we don't really know whether we're coming or going. And we had this early summer surge. The acuity has been there, but it's not been potentially like other winters. And when we think about a child with bronchiolitis and treatment, if you have a child who is desaturating and you give them oxygen, you're giving them oxygen because they are hypoxic, and not because you are using that oxygen to treat the primary bronchiolitis. And I know that's a rather forced point, but there are actually many things in paediatric practice in which we use an intervention to bide a child a period of time, not really to treat the underlying disease process. And there are good examples, and I'll go back to bronchiolitis, whereby if you look at the studies that have been done of nebulizers, whether that's a nebulized hypertonic saline or nebulized adrenaline, and you compare that to some form of placebo arm, in fact, the placebo arm in these studies, which is often either nothing, which is fine, but is often a nebulizer of water or simple saline. If you give a child with bronchiolitis just a nebulized saline, their respiratory rate will change and some of their breathing difficulty will change. Not for very long, but it does change. And we know this because we can look at the outcomes of placebo-controlled trials. And so working out what true treatments are is actually really difficult. And so I go back to this point of, are we looking for it to treat symptoms, or are we looking for treatments to be an actual cure? And to reinforce a point, let's think about talking therapies or mental health. They are definitely treatments. And we know that cognitive behavioral therapy and a number of psychologies do produce tangible benefits. But clearly they're not a medication in the sense of the word that you're giving something to someone to change their physiology. And so I think this concept of treatment does bear further review, and mainly because in paediatrics, and especially paediatric emergency medicine, so many children get better regardless of what you do to them. And COVID has really hit home on this point in an absolutely huge way, because for a period of time in March 2020 to about June 2020, we had far fewer children presenting to emergency departments with a very different symptomology than we normally see. And it did make us think about the things that we were doing and why we were doing them. And to take up the bronchiolitis example again, if we had had a wave of bronchiolitis during that period, which we didn't, and I think that would not have been possible because we were reducing the viral spread because of social distancing, etc., etc. But at the same time, because we weren't allowed to use aerosol generating procedures, I can bet your bottom dollar that the use of high flow would not have been as ubiquitous as it had been in 2019, because you would have had to have gone through all the paraphernalia of putting masks and gowns and everything off, and there would have been this smaller barrier to adopting a treatment. So COVID-19 has enabled us to look at things in a slightly different way. And the primary thing which happened was an edict from the RCPCH saying that a coughing child was in themselves an aerosol generating procedure. And there was a guidance from the RCPCH that where possible you should stop or reduce doing throat examinations in children. And this was a brilliant initiative because actually it enabled us to really look at our treatments of a very common condition, that being of tonsillitis. And it prompted some colleagues of mine to really force a question that has been going on for a decade or so, but that we've never really grappled with, about why we do give antibiotics for throat and ear infections in children. And the reason has been is because it's thought that they treat bacterial infections. But actually, we've known for a while that what we're really trying to do is reduce the complications of serious bacterial infections rather than the tonsillitis or the otitis media itself. And the biggest group at risk are those who are immunocompromised, those are particularly either indigenous populations or those with a true biochemical kind of immunocompromised condition. And we were suggesting that actually we should just decide whether the patient was in a high-risk group for whatever reason, and if you are, you get antibiotics, and if you're not, you don't. And that seems very simple, and there's absolutely nothing new about that at all. The Royal Children's Hospital in Melbourne, since 2019, have saying that their antibiotic therapy is only recommended for this high-risk group of children to prevent complications of Group A streptococcal infections. And to my knowledge, Melbourne have not experienced lots of problems with adopting what is actually quite a radical approach. And even in my own emergency departments here in Leicester, there is quite considerable divide on the shop floor between who gives antibiotics for these types of simple infections or not. But I really wanted to make it quite clear that if you are prescribing antibiotics, you are really doing it to prevent complications which are extraordinarily rare. And the number needed to treat, i.e. the number of patients that you need to treat to have a benefit, is 4,000 for both quinsy after tonsillitis and mastocytitis after otitis media. And so the rationale for giving antibiotics in these situations starts to become less and less and less. And I think COVID has given us an opportunity to really start pushing forward on this message. But yes, I hear you say, Damian, but these are infections which are relatively self-limiting and will go away. And we can't apply that principle to lots of different infections. I would argue, actually, it's all a question of risk. And so if we take our prototypical less than 3-month-old infant, and as Tom was talking about at the beginning of the day, if you have no risk factors but a temperature, there is a chance of serious bacterial illness. And that chance, in repeated studies, both Tom's and those done in America, shows somewhere between 9 and 12%, whether that be from UTI or a true bacterial meningitis, however rare that might be. And the question you ask yourselves then is, actually, when does 9%, or when does that percentage risk become relevant to you as a clinician, and I suppose more importantly to the parent? And as Tom was explaining, this concept of if we LP willy-nilly, for example, we do some harm. If you have multiple goes at doing a lumbar puncture and multiple goes at doing a cannula, you cause distress in that child. It might be short-lived, but there is some evidence to suggest that that pain may have some longer-lasting effects. But you clearly cause distress to the family, and that child gets admitted for a couple of days, which does have socio-economic consequences. And so in the previous slides, I showed some ridiculous numbers about, well, actually, you've got to treat 4,000 patients. Well, how many patients would you want to treat who have this risk of sepsis to want to treat them? And I think most people on this call, including myself, think, well, actually, if 1 in 10 children have something, I want to do something about that. But it's not as simple as just defining the criteria that I have just done, i.e., you've got a fever and you're a certain age, because we have this conundrum that some children don't have that fever in the emergency department, that the parent reports a fever. So what do? Do you wait in the department waiting for that fever to emerge? Do you take that fever on face value? Even if the child has a temperature of 38, do you act on that? If the temperature is 37.9, do you act on that? We have this ridiculous situation whereby 0.1 of a degree can make a difference between being 2 days in hospital with IV antibiotics and just being sent home. And a lot of this is about gestalt, this concept of gut feeling. It's difficult to explain, let alone define. But from Nate Cooperman's large study in 2019, where they were looking at patients presenting who didn't appear overtly unwell, so i.e. they weren't critically unwell, i.e. hypertensive or in shock. And they asked the clinicians before they started doing treatments and tests, etc., what they thought their risk was. There was no association between the clinician's suspicion of a serious bacterial infection and their rate of positivity. And so that bodes the question about whether we can use kind of gut feeling or clinician gestalt at all in these particular situations to make decisions about risk. And that becomes a real challenge. And so with that question of risk, I'm showing a picture here, and lots of you will have a visceral reaction to this picture. And the diagnostic spectrum for this child, just on that picture alone, is relatively wide. They could have a simple upper respiratory tract infection. They could have viral-induced wheeze. They could have a more chronic asthmatic picture. They could have croup. If they had a very high temperature, and in fact their observations were extremely deranged, and in fact if we played maybe a video of this and the child started to look exhausted, would you consider more serious bacterial infections? So that the possibilities are wide, but this is a picture of a child I think we see quite commonly in the emergency department. And I'm just going to kind of pick from the air. Let's take croup, for example. And if this child was coughing like this because of croup, I think most clinicians on this call would give some treatment for that particular condition. If we take a number of children, and these dots represent children, and we give them dexamethasone, and we compare those same number of children, but those are given placebo, these rates in red are the number of these children who will return following a diagnosis of croup. So you can see if you take 100 children or so and give a group steroids for croup and some no one at all, less children will come back in the steroid arm. But actually, lots of children don't come back at all in the placebo arm. In fact, quite a significant proportion don't come back. And croup's another good example of, is the treatment for the actual condition, or is it just to buy some time for some symptomology to go away? We don't like symptomology in children. We want to give the parents something to hang their hat on. But you could argue there is no treatment for croup. We don't treat the virus. What we treat is either impending respiratory failure, and we do that with nebulized salbutamol, or we kind of try and get rid of a bit of stridor, which, yes, in the child who's working hard might cause them some harm, but actually, if they're relatively happy, they probably don't need it because they're just going to get better. And the number needed to treat in this situation is you need to treat 11 children with steroids to start getting any benefit from a return rate. And so my question again remains is, what is this threshold for treatment that we should start using? I'm fairly convinced that you need to treat huge numbers of children to find any benefit at all from tonsillitis or otitis media. I think you don't need that many children if you're worried about the consequences of kind of bacterial meningitis or serious infectious disease in the neonate. But when do we start getting to the stage where we think, well, actually, do we need to do anything at all with croup? Because you could argue that some of the mild croups could literally be sent home when that diagnosis is made. And I think we try and do that in our own emergency department, sometimes with or without dexamethasone. But again, I put that challenge out there. Now, I'm going to drop something which might seem like a bit of a curveball in here. But this concept of treatment and timelines, I think, is really important, because we had a really interesting and unique situation in 2020 where there was massive concern about children coming to harm because parents weren't bringing them to emergency care services because they were scared of themselves becoming well or their children becoming unwell. And there was this mandate to really avoid doing anything at all. And that caused quite some heated debates about actually, were children being denied treatment they needed, or were we just seeing the most unwell children because we'd removed from the emergency floor in our assessment units children who were who did present previously but normally were very well. And it brought out a great debate about what is a delayed presentation. And on one arm, we had a large survey of paediatricians within the UK, published in the Archives of Disease of Childhood in 2020, from the British Paediatric Surveillance Unit, saying yes, of over 4,000 paediatricians, 30 to 40% had seen direct harm from children presenting late because their parents were scared about the pandemic. And at the same time, I did an observational study which showed in 1,300 patients across a multitude of units, actually the direct impact of true harm from a delayed presentation only occurred in 5 to 10 patients. And how do we explain these competing viewpoints? Well, kind of part of that is just a mass effect. I think if you survey lots of people, everyone thinks of something in the back of their mind, whether that was truly harm or not. And we created this concern in the summertime that this was happening. But I think it's really important that we start thinking about our terminology, because this plays into which children do need to finish the treatment and those that don't. And I'm trying to push forward a debate about really defining these terms of late, missed and delayed. And I think they are truly different. A missed opportunity is an occurrence whereby a child presents to a healthcare practitioner just demonstrating signs and symptoms which could have required treatment, but those don't happen. And ultimately that child then presents again. Harm may or may not have occurred, but there was a missed opportunity to intervene. A late presentation is very different. A late presentation is what we often see in diabetic ketoacidosis, which I agree definitely needs treating. But a late presentation is when that child, because they've been losing weight gradually, because their symptoms have been coming on gradually, we look at a child and go, wow, why have you not brought this child in earlier? Whereas the parent has seen something far more gradual. Late presentations happen all the time. Okay? We accept those in paediatrics, and yet we stopped accepting them during COVID. And I'm interested in why that happened. But also a late presentation is things like some of these group A streptococcal infections are often interpreted as missed opportunities because the child had presented potentially 2 days earlier. But it might be at that time that they didn't have Group A strep. They had a simple viral illness. And then Group A strep, we have this time and time again. All of these high-profile media reports are all Group A strep with these children who may or may not have presented previously and then suddenly present with crushing disease. And I think that's late. To me, a delayed presentation is truly a result of something happening in a system or a health service or a public health initiative that causes families or maybe healthcare professions to actively delay children moving along a conveyor belt and being referred into hospital. And I think these are different things. And the treatments that we use for these things, or more importantly, the missed opportunities for treatment, bear reflection. Because I think we come under massive pressure in paediatric emergency care not to miss conditions like sepsis, sepsis in particular, when it's actually really difficult to do that. So, an aside, but the crux of what I want to talk about in treatments comes from these two studies. And from CAPIT, which is just to remind everyone, it's a very simple design. You've got a child, the clinician thinks that they need treating for pneumonia. This isn't a chest x-ray diagnosis, this is very pragmatic. On the shop floor, is the clinician going to give antibiotics for this particular lower respiratory tract infection? And if they do, they are going to be assigned a short or long course duration and a low and high dose. And so there are 4 particular arms that you could be in. And if you want a summary of this, please just kind of Google CAPIT and don't forget the Bubbles, who have done a study of the trial and a link to the actual paper. But there are over 800 children recruited over a couple of years in hospitals in the UK and Ireland. And all these patients were, excuse me again, sorry, discharged from the ED or an inpatient unit within 48 hours of admission. And the nuts and bolts is there was no significant difference in the primary outcome, which was the need for further treatment within 28 days in either long course or short course antibiotics. Now, a lot of people are concerned about this study is that not that many actually had x-rays. How many of these children had a true bacterial pneumonia? Well, it doesn't matter. This was a pragmatic trial. It was looking at what clinicians did. And what we find is it didn't really matter what you give, is that the outcome is going to be the same at 28 days. But most importantly, and I've tried to jazz this slide up with colour, but it didn't work, so you're stuck with a black and white version, I'm afraid. But let's take resolution of cough. So what we can see is kind of lower and higher doses, and the percentage of children who still have cough at 28 days is 20% of them do, but you can see even after 10 days, 60% of children still have cough. And this is really important learning in terms of when we think about treatments. So if you choose to give a family antibiotics for what you think is a pneumonia, you really need to start telling them that I'm giving this antibiotic because I'm hoping it's going to treat an infection, but your child is still likely to be having symptoms in a couple of weeks' time. And I think that's really important because that may help with representations or kind of shopping for other practitioners to resolve this cough, because actually it might well be that the cough that is the problem. And we can look at actually the duration, and it was the same thing, although there is a bit more of a signal here, is that if you give a longer course, the cough does seem to resolve slightly more quickly, but actually this probably isn't clinically relevant. I mean, we're talking about essentially less than a day or so. But there is this concept that the cough is still there. And one of the lead author of the study made this comment in the Don't Forget the Bubbles blog, that it's unclear about the importance of cough as a symptom when we're treating pneumonia. And I think people need to bear that in mind. And because of that, so I'm going to share this is research that we did in our own department. And we used to give prednisolone for children with wheeze and asthma. We've moved that to dexamethasone. You can see in both groups there are essentially equivalent number of patients. And the return rate, because the confidence intervals cross, it isn't statistically significant. There is a bit of a trend there, but actually this isn't a clinically significant difference, so we've decided to continue using dexamethasone in our department. But you can see that there is this slight trend. Why is that? Well, one of my colleagues, Dr. David Simpson, made this observation that when you just give a dose in the department, the family have got nothing to hang their hat on for the next 3 days, whereas prednisolone, the family think that they're getting something extra as each day goes on. And it's almost a true treatment as a placebo. That if you think you're giving something in the same way as lots of people think that if you give a treatment for bronchiolitis, at least you're doing something, even though that's not really going to change anything to the disease process. We're all hardwired to believe that doing something is important. And to make a point that this occurs kind of all over the world, this is from the famous apple juice study, a North American study where they looked at children with mild to moderate dehydration. Some got apple juice, some just got oral rehydration solution, and treatment failure as designed by need for IV treatment was much less in the apple juice arm. And so you can continue giving apple juice. What you can also argue from this study is that why did we give any treatments at all? Because actually the baseline observations were so not deranged. And I think we've got much better over time of trying not to do anything at all for gastroenteritis. And you really only need some form of intervention if you're on the verge of clinical shock, or you still have a true biochemical abnormality. But that international variation is important. And let's go back to bronchiolitis. You've got a little child, they seem to have features of upper respiratory tract infection, their breathing's going up, they've got no particular risk factors, and for all intents and purposes, they have a clinical diagnosis of bronchiolitis, respiratory rates up, they have a temperature of 38.1. And we posed this question to clinicians from the Peruki network in the United Kingdom and Ireland and Canada. And what we find is if you're in the UK, you don't do a lumbar puncture and you rarely do investigations, whereas if you're in Canada, loads of these children get LP and investigations. Now, they might not get treated, but the very construct of looking at this process is different. And the same applies if you look at testing for treatments for bronchiolitis across the world. You find that we do much less in the UK, and there is international variation. And I think this ability to then test and then treat has a cultural nuance to it, and I think that's something that we need to be aware of. And then just to finish off, because I've talked a lot about illness, is the fourth study. It reached its conclusion this year. It was looking at buccal fractures, and it was looking at whether you do need a splint to treat a buccal fracture or you can do nothing at all. Now, the study group wanted to do nothing at all, but the parent group within the study felt the parents would not expect no treatment, so we offered a bandage, and the bandage was literally wrapped around the wrist. It was doing nothing, but it appeared that this bandage might help parents become part of the study, and they did. And this study is going to report imminently. At the moment, it is under peer review, so I can't specifically state the results because they may well be published in the journal submitted to, doesn't want them displayed. But I will just simply say that my treatment for buccal fractures has become increasingly relaxed. But linked to the fourth study is something called CRAFT, which is looking at essentially quite significant risk factors, and typically you would look at those and decide that needs some form of manipulation. But if you don't manipulate this child's arm, it will eventually remodel. And we know that because there was a period of time in Hawaii where they were unable to sedate children due to a national shortage of anesthetic and sedative agents. So they just let these go, and that we have numerous examples of putting these children in casts, eventually re-healing them. This is hugely... Dan Perry, professor of paediatric orthopedics, is hugely pushing this forward, and lots of orthopedics disagree with him on his approach, and that's why we're doing a randomized control trial of this particular approach. But it will be interesting to see how a treatment that is completely embedded in our psyche may suddenly be withdrawn. So I hope you find that helpful. I've not given you specific answers, but I hope I've given you a lot to mull on in terms of the way that you practice medicine and you really think about the treatment you're giving and what effect it will have on the child and family in front of you. Thank you very much.
That's excellent, Damian. Thanks very much for that talk. Really, really enjoyable. Just have one question. Just to encap it, the primary outcome was time to resolution of cough. In the future, do you think we're going to see more primary outcomes which are more subjective or parent or patient-centred?
Well, actually, in CAPIT, the primary outcome was need for ongoing treatment within a month. So did you need more antibiotics or more interventions? The BID study, which was this study where Steve Cunningham changed what a SATS probe looked like, so you thought it was 94, but it was actually 90. They used cough as the outcome measure for parents there. And I think it is going to become more common, it will be symptom-based outcomes, because that's actually what is important for parents. That's going to be both a blessing, because it's going to make some of these studies much easier to do, because the outcome measure is much easier to define if you're doing a power calculation, but also it's going to cause controversy, because we as paediatricians don't like subjective outcome measures. We like to know, did we reduce admission? Did you reduce attendances to PICU? But that's not always the most important thing to families. And we've got a lot to learn, I think, over the next couple of years in that regard.
Excellent. Just a quick pointer on apple juice study. That's something that probably changed my practice a few years ago, and some of the clinicians I was working with, where we switched to apple juice, and there was some evidence that apple juice was the optimal oral rehydration fluid. But when you look at it, I think children were excluded if they had moderate to severe dehydration, so the evidence is probably quite weak. Is there a danger that maybe people derive their own conclusions from studies based on the abstract or based on the headline?
Yep. Okay, that's an excellent question. So yeah, no, I agree. I think that there's an element of professionalism here. If you're getting to the stage where you think that someone who is honestly seriously dehydrated and has clinically going to get by with some very simple agents, I think that becomes challenging. Where I do think the misinterpretation comes from that study is it was, well, apple juice is better than oral rehydration solution. Actually, I'm not sure that's the case. My interpretation of that study is we don't really need to chase down children who are mildly to moderately dehydrated, and they can probably go home. And we don't need to spend hours with a fluid trial with them, and we probably don't need to spend hours trying to chase urines. And this is the challenge. This international comparison, I think, is important, because there is a very different culture in North America than there is here in terms of risk assessment and risk profile. So I think even in that study, I think there will be a lot of children who may have got interventions that we would not have considered here in the UK. And I think that makes it difficult. And we probably need our own UK-based dehydration management study to really put this issue to rest. I would love to do a study that supports earlier discharge of children with moderate dehydration, because I think we become very anxious about it, and we make parents more anxious because we keep them in hospital observing them, and it would be better just to send them home.
Excellent. Just another quick question just on the febrile neonate, the febrile child under 8 weeks. It seems that we're kind of stuck at that 8-week period if the risk of serious bacterial infection is about 9%. It seems like the theme of the talk was pulling back on interventions and investigations, but it seems that's a point that's probably going to be hard to overcome. Where do you see us going in the future, or what kind of clinical decision rules could influence our practice?
I think we're going to be stuck with the 6 to 8 weeks for a while. I think we will improve, and I hope actually the mandate of under 3 months will eventually go. In my lifetime, there is the possibility, given some of the research that has been done recently, is that we will go full protein and genomics, and that children presenting who may have an infection will just have a drop of blood taken for their genes to work out if they have the ability to fight infection. I think a number of people are increasingly believing now that there's no way, given the fact that antibiotics only came widespread in the last 100 years, that how would we have evolved if all children who got these infections, tonsillitis, that died. They don't. So lots of people in our population can fight bacterial infection, including probably meningococcal disease and including streptococcal disease. And we know that because there are studies that are done that have sent children home who have grown streptococcus in their bloodstream and they don't die. So it's probably a genetic thing that some people are just really good at fighting infection. And if we can work out who they are, we might not need to treat them. And the only people we target are those that we know are at risk.
Excellent, yeah, I'd agree with all that. Just looking in the comment section. Give me 1 second. I have no more specific questions, Damian. I'll give you the last word. Is there anything else you'd like to mention, or anything else coming up on the horizon from Peruki that you'd like to mention or for us to look out for?
Yeah, so I mean, if you're not already a Breaktime site, please do continue to continue recruiting for that. I know it feels a bit of a bind and it's been going on for ages. There is evidence that we've had an early summer surge that's dying off. There is real concern now that in France it's come back, and what we might find is after Christmas that we will see the return of bronchiolitis, maybe in a much more dramatic way than we saw earlier. I don't know, but that some of the data seems to suggest that. Thomas talked about FIDO. We're looking at bigger randomized controlled trials for the treatment of febrile infants, and we have, I think, some exciting studies coming about UTI and limping children over the next year or so.
That's brilliant, Damian. Thanks very much for your time and for your talk. Really enjoyable. I think that's it for today. We might wrap up the conference there. Really enjoyable morning and afternoon. I hope everyone else enjoyed it as much as I did. I just want to thank Jake Fudge, our multimedia technologist, who's sitting beside me throughout the morning, doing a lot of work in the background just to make sure everything goes as smoothly as possible. We enjoy putting on these conferences, and we hope to do another one in the new year. I hope you all enjoyed it, and yeah, leave your comments in the comment section, and any feedback you have is much appreciated. Oh yeah. Also, if you register on the Zoom link, even though if you didn't actually attend or view it on Zoom, you can get a certificate of attendance just for CBD or for your portfolio. So make sure you register via the Zoom link, and we'll send you a certificate probably next week sometime. Okay? Okay, we'll call it there, guys. Thanks very much for attending.